Hi guys, hope all of you are doing great. Jai Hind and happy pre-Independence Day to everybody. So let's get started. I am very sure that all of you would be preparing very well for the forthcoming exam. And what I will do is not take too much of your time. I'll try to focus on the core and the crisp aspects which are actually required. So what we will be doing is try and solve those PYQs once again so that in case they come, we don't make any errors. And what I will also do is I have deliberately, in fact, made slight modifications in the language of the question. Though initially the stem is still the same, but what I've done is in some of the questions I have deliberately like modified the stem so that I can tell you about the permutation combinations that they can be giving to you. So obviously don't get like carried away by the fact कि अरे यार ये question तो मैंने पहले करा हुआ है तो इसका आंसर यही होगा, because lots of time these slight modifications in the language and the presentation can also change the final output. So with this, I think we are good to go for today. So the main session is I will be covering MCQs year-wise. We'll be going retrospective from 2025, 24, 23, and then 2022. So this is like your one-stop solution for all those MCQs. And as far as the theory is concerned, that would be in the app on 17th. That is when we'll be doing the entire session from the perspective of theory as well. So, okay, let's get started, man. The first question is a repeat from 2025. So we're going year-wise, as I've said, retrospective study is the methodology today. A lot of people are not able to, fathom it out or figure it out, वो सोचते हैं सिर्फ थ्योरी पढ़ने से MCQ होते हैं, ऐसा नहीं होता ना, MCQ पढ़ के भी थ्योरी करनी होती है. So let's decode 2025 paper and don't comment only on A, B, C, D. Do try to also give 1 or 2 line rationale if possible in the time that is available to you. So we'll be quick, we'll be crisp and precise for these questions where we have this 30-year-old patient with 6-month history, progressive shortness of breath. I mean, that's the opening line of most of the questions. And then it's a cardio question because JVP is elevated irregularly. Regular pulse tells you atrial fibrillation. Hepatomegaly tells you that the right ventricle is also getting involved, and then a rumbling mid-diastolic murmur with a history of rheumatic fever. So the diagnosis is pretty straightforward. This is a case of rheumatic heart disease with mitral stenosis, and there is a atrial fibrillation that is present. Now, in these patients, obviously there would be structural damage to the left atria. So clot formation will obviously be occurring, and therefore increased risk of embolic stroke is something that I can pick up immediately, and there would be absent A wave in atrial fibrillation. So two statements are like easily ruled out. One is right heart failure. You could see hepatomegaly present. So the answer in this question would be that the traditional murmur that is found in this condition is a mid-diastolic murmur with like that pre-systolic accentuation. But as I've explained that in atrial fibrillation, because the atria are twitching, तो उनमें ताकत ही नहीं है. Because of the ताकत, that pre-systolic accentuation which is given in this question is a wrong statement. I would like to inform you that this question also came in INI-CET exam in a different way in 2024 and was repeated in NEET PG in 2025. So the diseases will remain the same. The disease will remain the same. The only thing is the language of asking it would be changing, and Medico X has done a perfect job. There is no atrial contraction. So that is the rationale that in this condition, there would be a lack of pre-systolic accentuation, and therefore the correct answer to this first question is option number A. So good job, everybody. I had good comments, and I would like you guys to keep on commenting pretty fast with a bit of a rationale so that you are able to practice it for the exam simulation. We move to the next question, which was a one-liner. Which of the following leads to hyperpigmentation in Addison disease? Though I have talked about story for Addison disease for the chief of Al-Qaeda, but today we will not get into that story because we have to solve MCQs. But anyway, there's a hyperpigmentation present. So what we need to pick up here is that in this condition, because aldosterone, cortisol, as well as sex steroids are less, so by feedback mechanism, ACTH levels will begin to rise. Now, if you look at the question was very smartly designed. ACTH is written as a false. So obviously the answer cannot be option number B in this question. Obviously, there is a precursor that is responsible in this case, and the precursor is called as pro-opiomelanocortin. Yep. Very right. This is correctly answered as option number A. Rise of pro-opiomelanocortin is the reason for this, because pro-opiomelanocortin then breaks down into ACTH as well as alpha MSH. So this is a precursor that you just need to pick it up. I'll repeat the statement once again. POMC will break down into ACTH as well as alpha MSH, and that alpha MSH is the one that's responsible subsequently for that hyperpigmentation that is seen in patients of Addison disease. So good job. The answer to the second question of NEET PG 2025 is option number A, and we go to the next one. A universal question on diabetes will always be there. A known case of type 1 diabetes is sleepy. There's a evidence of dehydration. Sugar was like, students were very particular. 799, ऐसा लग रहा सेल चल रहा है, right? Bata का sale 799, sorry. And then sodium was low, understandably. Sugar is more, it will draw water. And that drawing of water will result in hyponatremia in this patient. Then you can notice there is a chloride component lesser. The reason for that explanation for that low chloride can be vomiting now, because if a patient is having severe vomiting due to diabetic ketoacidosis, the chloride will be relatively less. He says, which of the following will not be used in the initial management of this patient? So obviously we will be using normal saline in the patient. We will be giving insulin for this person. And when the random blood sugar of this patient will become less than 250, when the random blood sugar of the patient will become less than 250, that is when we would like to give 5% dextrose to the patient as well, because a sudden change in the sugar values will again cause osmotic changes across the brain, and the fluid shifts across the brain is dangerous. We don't want to take a chance in this particular case. So obviously there is no role of 3% saline, because we are not like, there is no need for hypertonic saline in this patient, because as I said, the condition is due to osmotic shift of, it's rather water coming in because of high sugar, which is causing that hyponatremia component. So if you will treat the hyperglycemia of the patient by giving insulin, then there is no requirement for hyponatremia being treated with 3% saline. So the correct answer to the current question is option number B. We did have a bit of slight deviation initially, but then most people were able to subsequently come to the right track. So good job guys, and I'll try to keep it faster, because at the moment our objective is to just revise those questions so that just in case they come, we should be spot on with answers. And the logic I will say once again, because I got comment in some of the comments as D as well. If random blood sugar becomes less than 250 during treatment, this is the statement that you need to remember. During treatment, if the random blood sugar becomes lesser, that is when we might be using 5% dextrose. Okay, so next is the patient with severe respiratory distress, and the PO to FiO2 ratio is 100 only. Norm PO to FiO2 ratio less than 300 is ARDS. So the question is with respect to acute respiratory distress syndrome. ARDS is a condition where we ventilate the patient. We deliberately keep the tidal volume on the lower side because we want to minimize the barotrauma. Because otherwise, if I do the routine ventilation at 12 ml per kg, the risk of damage to the alveoli is substantially very high. So I need to go for low tidal volume, but at the same time, I would like to deliver more PEEP because I want more recruitment. You see, there are two objectives which I want to revise at this moment. That is the core thing with respect to management of ARDS patient on a ventilator. One is to minimize the chances of barotrauma, because of which we will like to keep a low tidal volume. But at the same time, I would like to also do recruitment of the alveoli, because you see the alveoli are damaged after all. The production of surfactant is also lower. So during the end expiration, the alveoli are supposed to collapse and the gas exchange would be compromised. So the textbook says that there are two things that the doctor has to ensure. One is recruitment of alveoli, especially end expiration, and minimize the chances of barotrauma. So therefore, it would be a low tidal volume and a high PEEP that would be required. And therefore, the correct answer for this question is obviously option number B. And yep, you need to keep on commenting regarding the reason and the rationale for the same as well. So we are sorted for this question. And now is that question that always has to come. There would be a patient who would be having low sodium on admission. He had development of seizures. You have given correction with hypertonic saline after 24 hours. Remember, osmotic demyelination syndrome ekdam se nahi hota. Osmotic demyelination syndrome manifestations will develop after 24 to 48 hours, where stroke-like manifestations would be present. So what happened in this case was that the sodium was elevated from 98 to 110. That would be a mathematical increment of 12 points. Now, as I have explained to you, the increment should not be at a rate of 12 milliequivalents per 24 hours. Here, there is a wrong increment that is happening. The doctor has been a little more aggressive. The increment should be in the range of 6 to 8 milliequivalents. We did an increment of more than in the range of 12. So therefore, I can say that mathematically speaking, the increment, because it is much more higher, osmotic demyelination syndrome is occurring. So I would like to identify that Shivji ka Trishul. That Shivji ka Trishul would be showing that presence of trident sign, that is osmotic demyelination syndrome, formerly called as central pontile myelinosis. So we would like to go ahead with option number A for this condition. Lumbar puncture, well, there's no evidence of any meningeal signs in this case, so it is ruled out. Brainstem evoked auditory potentials. If there was something related to auditory nerve, I would have thought about it. And EEG, yeah, it makes sense, but then at this moment, like instead of doing EEG, I would like to document the demyelination occurring in the brainstem of the patient. There would be stroke-like manifestations, and therefore MRI head would be the best investigation. So this was easy peasy kind of a question in the paper, and most guys were like, okay, this was like much more very, very easily solved. The next question that I'm saying has a bit of pathology overlap. Yeah, we have to slowly correct hyponatremia exactly. A word of caution there, acute onset hyponatremia, we go in for bolus, but for chronic onset hyponatremia, we go in for a slow correction. And in this question, there was no mention regarding acute versus chronic. So the increment of 12 is like something which is not, I'm very comfortable with. Okay, so conservative management is done in this case. Once the damage, no point of, if milk will fall out of a glass, if you spill milk, you can't put that milk back in the glass, right? So damage is done. That's like, rather I'll be preparing my defense for medical legal case in those circumstances. Okay, next one is very simple. Fever, malaise and fatigue for past 1 month, and there was a hilar lymphadenopathy that was given in the question. There was presence of circular lamellated concretions and stellate bodies on histopathology. So that stellate bodies I think everybody could pick this up. That is asteroid bodies and Schaumann bodies in a patient with hilar lymphadenopathies. So the answer in this question, no guys, it is not a cat scratch disease. Cat scratch disease में तो stellate granuloma होगा ना भाई, इसमें ग्रैनुलोमा कहाँ लिखा है? मतलब ओवर कॉन्फिडेंस भी नहीं करना है इतना ज्यादा कि गलती हो जाए. क्या इसमें ग्रैनुलोमा लिखा है? नहीं लिखा ना. इट इज टेलेट बॉडीज, दैट वुड मीन स्टार लाइक फीचर्स. एंड देन अगर किसी को कैट ने स्क्रैच किया तो कहाँ पे मतलब अगर कैट ने स्क्रैच किया तो क्या हाइलर लिम्फेडिनोपैथी होगी? नहीं ना, वो तो एक्सिलरी लिम्फेडिनोपैथी होती है. या फेस पे, गर्दन पे, जैसे कैट को, बच्चे कैसे छोटे कैट के किटन को कई लोग उठा लेते हैं ना, तो कैट ने फेस पे स्क्रैच किया तो कान के इधर के लिम्फ नोड, एपिट्रोक्लियर लिम्फ नोड, सर्वाइकल लिम्फेडिनोपैथी होती है. You would have seen so many videos ना, people were playing with cat ने ऐसे फेस पे मार दिया, तो then it is gonna be like epitrochlear or cervical lymphadenopathy. हाथ पे काट लिया और स्क्रैच करा तो then it would be a axillary lymphadenopathy. तो hilar lymphadenopathy तो नहीं होगी ना यहाँ पे. So obviously like hilar lymphadenopathy is a feature that you get with rather sarcoidosis, and then is the Schaumann bodies which are like obviously mentioned here, and then is the asteroid bodies which are given in this particular case. So the answer to this question is option number A. So I think we are sorted for this one at the moment. And biochemistry, man, like doctor, you drop me an email, right? And then I will be in a better position to guide you. Okay. The next one is regarding joint replacement surgery. The patient developed shortness of breath and the blood pressure is holding at the moment. I will be discussing the updates in the app session with respect to pulmonary embolism. I mentioned them updates on the YouTube session. The rules are still the same. If BP is crashing, you need to do thrombolysis in a patient. And since in this patient, it is hemodynamically stable, so there are only two options which are left before you. Obviously, ECG and chest X-ray, to matlab, they are supportive evidence. I need to identify what is the problem. Since this is a high-risk patient, so I would like to go in for a CTPA for identification of this condition. However, suppose in this question there was mention of any contrast allergy, or there was risk of contrast-induced nephropathy, like there was significant renal dysfunction that is present. And I would like to once again reiterate that in contrast-induced nephropathy, we do not use N-acetylcysteine. That is one of the old data. Like somebody had pinged me recently saying, sir, N-acetylcysteine is the antidote. No, man, it is IV fluids. We'll flush the kidneys of the patient, but there is no role of like N-acetylcysteine nowadays for management of this condition. Only in pharmacology it is written like this, and in older books it was given. But yeah, N-acetylcysteine is not the antidote, it is conservative management. So coming back to the agenda, if the question mentioned renal dysfunction, pregnancy, in those circumstances, I would have answered it as a ventilation perfusion scan. So V/Q scan is in those patients where there is a low index of suspicion of pulmonary embolism. Here, if you look at all the perspectives very significantly, especially joint replacement surgery, third day there is a manifestation, so that it itself is like telling you that immobilization of a patient after joint replacement is going to be a risk factor. And then there's a desaturation happening. The old man advanced age group is again a high risk factor that is present. So CTPA would be the best investigation for this condition. And then subsequently thrombolysis with low molecular weight heparin or unfractionated heparin would be used. In fact, if it says what will we do in this patient, it can either be a catheter directed thrombolysis, but yeah, I mean thrombolysis is one that would be for the thrombolysis part. Again, I'm like, blood pressure is like 100/70. If it's in a falling phase, that is when thrombolysis. So I can say at the moment, like, my treatment will start with heparin in this patient. And then the second step in the management of this patient will be, I will take a decision on the basis of the echocardiography report and the subsequent blood pressure, because one blood pressure value will not be reliable for, like, deciding what is to be done. But if the BP is progressively falling in this person, then we might decide to use L-Teplis for management of this patient. So somebody had commented L-Teplis right away. So I just want to bring to your attention that L-Teplis is only when there is going to be a significant right ventricular dysfunction given in a question, when there's a significant fall in blood pressure of a patient. So if he gives you that sense of falling of blood pressure, that is where I would like to do. Otherwise, my first answer in this case would be unfractionated heparin to be done for medical management. I hope it is clear, guys, that the indication for L-Teplis, I am using two different colors to highlight that as of now, it is not in favor of using L-Teplis because the BP is doing more than 90/60. But yeah, if he mentions evidence of right ventricular dysfunction with a falling blood pressure, that's where I would be more comfortable using thrombolysis in the patient. So we are sorted for this question. The next one is regarding sudden onset aphasia, right arm weakness for the past 4 hours. The patient has an irregular pulse that indicates obviously atrial fibrillation. And you have stabilized the patient. Now there's a diagnosis of ischemic stroke. So what is the most appropriate investigation to determine the etiology? So basically the question is talking about cardioembolism. And when I talk about cardioembolism, atrial fibrillation, I can document that on the basis of ECG, and then I can also do a transesophageal echocardiography for this patient. At this moment, I would also like to state that if this irregular pulse was not mentioned, then the answer can be carotid Doppler also. In fact, I would like to do a CT angiography and or MRI angiography, whatever is available, because when we do a CT, we can evaluate the carotid artery in the sections as well to pick up the atherosclerosis of the carotid artery. So a word of caution for all of you is that if I remove the word irregular pulse from this question, if I just remove irregular pulse from this question, then do take care of the fact that carotid artery atherosclerosis is also gonna be a reason for development of embolic stroke in a patient. So as a result of it, carotid Doppler will also become an answer. But yep, considering the information that is given in this question, yep, the answer is transesophageal echocardiography. I've given the rationale for the same. If I remove this, the answer changes over to a carotid Doppler. Do take care, mental note of the fact that even carotid artery atherosclerosis could be like the reason behind development of acute ischemic stroke in a patient. This was a question that caused a lot of heartburn to those who had not listened to the fluid and electrolytes. The remaining people were very easy. The patient was given an IV fluid and there was a hyperchloremic metabolic acidosis. Side effect of the fluid is given in this case, and the answer is normal saline. क्योंकि जब हम normal saline देते हैं patient को, तो negative charges chloride की value बढ़ जाती है. And when negative charges are more, the body will be sending bicarbonate inside the cells, and bicarbonate in the body will decrease in the blood, and therefore acidosis will be a manifestation. Though a lot of guys were able to pick up the word hyperchloremic, so उससे solve कर लिया कि सर normal saline ही बन रहा था और तो hyperchloremic कौन ही करेगा. And then the logic I'll say once again, negative charges in the body are rising क्योंकि क्लोराइड की मात्रा बढ़ रही है. तो बॉडी ने क्या करा, बॉडी इज लाइक द ग्रेट ग्रैंडमदर. वो कहती है नहीं नहीं, मुझे बैलेंस मेंटेन करना है. उसको क्या बोलते हैं, इलेक्ट्रो न्यूट्रलिटी. तो इलेक्ट्रो न्यूट्रलिटी को मेंटेन करने के लिए बॉडी ने बोला नेगेटिव चार्ज को, बाइकार्बोनेट को, कि तू ना अंदर चला जा सेल के अंदर. अब बाइकार्बोनेट की वैल्यू अगर ब्लड में कम हो जाएगी तो देन इट्स गोना कंट्रीब्यूट टू मेटाबॉलिक एसिडोसिस इन अ पेशेंट. द रैशनल बिहाइंड दिस क्वेश्चन इज मेंटेनेंस ऑफ इलेक्ट्रो न्यूट्रलिटी व्हिच इज रिस्पांसिबल फॉर डेवलपमेंट ऑफ hyperchloremic metabolic acidosis. So the answer to this is obviously option number B. Yep, Medico X, you said the right thing for this. Next is a patient comes with fever, with headache, nuchal rigidity. I mean, one question of meningitis is by default always gonna be there. Gram-negative diplococci are present, and then he says, what would you be giving for chemoprophylaxis in this question? I'm waiting for your answers for this one. Guys, you are rushing into the answers. Question is with respect to chemoprophylaxis. The question is not asking you the treatment. The treatment for this condition is obviously ceftriaxone with vancomycin. That is okay. But the question is with respect to Beta, the question is not on the treatment. The question is for meningococcal meningitis ka prophylaxis. The answer for this question is option number D, that is rifampicin. If the question said what is the treatment of acute bacterial meningitis, it is ceftriaxone with vancomycin. For prophylaxis, it is rifampicin that is used. And for prophylaxis, I want to always highlight that obviously, like we have already discussed this, so I'll not get into it. CMDT says that ciprofloxacin is gonna be more effective as compared to rifampicin. So don't jump into answers in the question. And yep, this is more of preventing a silly mistake. I'll be discussing about 90 questions in 90 minutes before you. At the end of it, do keep a tab on how many you got right and how many you got wrong. And in PYQs, you are supposed to have a 100% strike rate. Because if you get a PYQ wrong, then your rival will score over there. So you cannot be missing on even a single one there. So I want you to have something like 80 out of 90 because all of these are previous year questions. But ideally, I would suggest you to have a perfect strike rate in each of these questions, because in case they're repeated, I mean, I would not like to utilize that opportunity I would not like to miss out on that opportunity which my rival will grab immediately. So empirical therapy, exactly, doctor. This is chemoprophylaxis. We are not talking about empirical therapy. The question is not on empirical therapy. I'll just the arrows here tell us that A is not matching with the language of the question. Empirical therapy was ceftriaxone with vancomycin. Here it was the prevention part in the question. Okay. Moving to the next one, a patient presents with morning stiffness, positive for anti-CCP antibodies. So we're talking about rheumatoid arthritis. And a rheumatoid arthritis, the highlight from the pathological perspective would be a pannus formation and erosive joint damage. So we can get a swan neck or a boutonous deformity. This was like ultra easy. Pannus formation and a erosive joint damage would be present in this case. Okay, great. Yep. Now is a 55-year-old man with altered sensorium, deep labored breathing. ABG is given. All the three values are going down. pH is less, PCO2 is less, bicarbonate is less. So it is metabolic acidosis. If I do a mental calculation, the value of anion gap in the patient is elevated. So this is like a high anion gap metabolic acidosis that is given. And if I just expect like if I do a Winters formula, then the expected PCO2 in this patient, that would be 16 plus 15 is equal to the actual PCO2, because the expected and the actual PCO2 values in the patient are matching. So this means that the compensation process is working, and this would be a case of metabolic acidosis with a compensatory respiratory alkalosis. So spot on here. Obviously it's not fully compensated because उसके लिए तो pH normal होना चाहिए. And if I say uncompensated, जब the rule Winters formula is getting satisfied, that means compensation process is working in this particular case. So answer to this question is option number A. And we move to the next one, where a diabetic patient is on metformin at the moment along with glargine. HbA1c is elevated, suboptimal glycemic control is there, and he's having like heart failure. I mean, that's what he's trying to say, heart failure with a preserved ejection fraction. So the drug that we'll be using in this patient would be empagliflozin. I mean, the main drugs that we use for this condition for preserved fraction would be SGLT2 inhibitors, then is finerenone, and then is obviously like empagliflozin. That is one of the main drugs, that is one of the main things that you can be using to fight against heart failure with preserved ejection fraction along with ARNI. So SGLT2 inhibitor, finerenone, ARNI are like one of the pillars for management of heart failure with preserved ejection fraction. So okay, I mean any diabetic kidney health would be hampered. Kidney health will affect the heart health as well. So why to take a chance? Cardio protection is what is supposed to be given. This question caused a lot of heartburn because all the options for the question were like, I would say, okay, you read it first, then I'll make you analyze it. Pink frothy sputum dyspnea, patient died. So there is evidence of left ventricle failure, and you can see heart failure cells. So the guy was having a chronic heart failure. Then there's an acute decompensation occurring in this patient. So he says, which of the following is least likely to occur in this patient? Least likely to occur in this patient. So volume overloading तो होनी है, pulmonary venous hypertension भी होना है, because if left ventricular end-diastolic pressure will be more than left ventricular end-diastolic pressure means left atrial pressure will be high and pulmonary venous hypertension would be present. And then left ventricle failure causes right ventricle failure also, na? Right ventricle failure causes left ventricle. You get a protein losing enteropathy, but then the question is with respect to what is going to be least likely to happen in this question. So I can say that this question caused a lot of heartburn, because like all of the options are correct, and we also have as a protein losing enteropathy due to chronic heart failure in a patient, but that is a very late manifestation. So that is why the answer should be given as option number D for this. Protein losing enteropathy is usually seen with inflammatory bowel disease and Menetrier's disease. I'll just write down the causes. It is seen with inflammatory bowel disease, it is seen with Menetrier's disease, and then it is also seen with chronic heart failure. It is chronic right ventricular failure that would be responsible for this. So I can say that left ventricle failure is causing right, but then because patient has died, so maybe that chances of development of increased pressure in the mesenteric circulation was not possible. Yep. So we are sorted for the current question, and next one is fatigue, pruritus, and jaundice with gross elevations of SAP that tell me that it is obstructive jaundice. There is conjugated hyperbilirubinemia. So I know that I'm dealing with a primary biliary cirrhosis. And for primary biliary cirrhosis, it is anti-mitochondrial antibody that would be responsible for this. No, beta, this is not autoimmune hepatitis that you might be suspecting. This is not autoimmune hepatitis type 1 that you would be suspecting. That is a separate question. Woman comes with lupoid manifestations given and then hepatitis. So that's autoimmune hepatitis type 1, where you might think in terms of anti-nuclear antibody. This is pretty straightforward, anti-mitochondrial antibody for the manifestations. Okay. Then is a lady with dysphagia, weight loss, and bronchiectasis. Barium swallow is shown. So you can notice that there is evidence of the tapering at the lower part. So this tells me that this is HLA-cardia. And to confirm the diagnosis of this particular case, what I should be doing is a manometry. And the manometry will be revealing an increase in the tone of the lower esophageal sphincter. Because of that, khana niche nahi jayega. That is why like the symptoms of progressive dysphagia are developing in this case. So an esophageal manometry would be the best one to identify this. The evidence would be that of aperistalsis and increased tone of the lower esophageal sphincter due to loss of inhibitory control due to damage to the Auerbach's plexus. The next question caused a lot of heartburn because this was on pheochromocytoma with palpitations, headache, and diaphoresis. The PhD manifestations, 24-hour urinary metanephrine levels were elevated. So everybody could pick up pheochromocytoma. The only problem in the question was preoperative and postoperative and intraoperative. I mean, both situations were given. So if it was preoperatively, I would have answered as a phenoxybenzamine. But because the question was mentioning both preoperative as well as intraoperative, then it is nicardipine. That would be a better answer for management of this question. You are right, we would like to use a alpha plus beta blocker for pheochromocytoma, but this question was like which can be used both pre as well as intraoperatively for control of blood pressure. So a calcium channel blocker would help you in controlling, or usually traditionally for intraoperative we use sodium nitroprusside. That is what Harrison says, but after that nicardipine can help you in regulating the blood pressure of this patient. Okay, fine. Next is about, again, irregular pulse and palpitations. The symptoms are there of atrial fibrillation for the previous 2 hours, and there is no mention of any hemodynamic crashing of the patient. So cardioversion is ruled out. Like in this question, if he had specially mentioned like patient had become unconscious or there was chest pain, there was some evidence of cerebral ischemia, I would have thought in terms of cardioversion. But considering the fact that any patient of atrial fibrillation, if he is hemodynamically stable, we would like to go in for race in this particular case. That is, first is rate control, then is anticoagulation to be done. So the correct answer for this would be control the ventricular rate with verapamil for this case. So yep, the correct answer for this one is option number C. Okay. Then is a man with chronic kidney disease. He is presented with complaints of increasing fatigue, dyspnea on exertion, and is found to have a pallor. Hemoglobin was 7. There was evidence of normocytic normochromic anemia, and in any patient of CKD, If the patient is not on hemodialysis, we would like to give oral iron for the patient. If the patient is if patient is on hemodialysis, we would first like to give IV iron to the patient and then give darbepoetin. If the patient is not on hemodialysis, so I've written ST negative. By ST negative, I mean there is no hemodialysis that is being done at the moment. Then we can give oral iron for management of this patient. The reference is from the textbook only, that adequate bone marrow stores should be available. Adequate stores should be available before treatment with erythropoietin stimulating agents should be started in this patient. So considering the fact that in this particular case he is asking what is the first step, the answer to this question is option number A. Even in the actual paper, a lot of people had answered this as darbepoetin alpha. The question, if it said what is the main treatment, obviously like in chronic kidney disease, erythropoietin production is lesser, so the treatment of choice is darbepoetin alpha. I don't dispute that. But at the moment, the question is not asking you regarding what is the treatment of choice. He is asking you कि पहले क्या करोगे. So the initial step in the management of this patient would be that you build up the iron stores, because there is no point of, that is what I've given the textbook reference also, that in the setting of iron deficiency, क्योंकि ठीक से खाएगा भी नहीं, सीकेडी वाला नोजिया वॉमिटिंग रहती है, तो मतलब एपिटाइट भी रिड्यूस हो जाता है. सीकेडी इज अ कैटाबॉलिक प्रोसेस. सो व्हाट वी शुड डू इनिशियली फॉर मैनेजमेंट ऑफ दिस पेशेंट्स इज build up the iron stores. Yeah, we should check ferritin in the patient. Exactly, that is the current guidelines. We should check for the transferrin saturation. We should check ferritin. In fact, ferritin भी falsely elevated हो सकता है. So what we should be doing for management of this patient is ideally, like that is what is mentioned here, CKD में we should be checking is the percentage transferrin saturation. That is again an update that came up. It's already in Harrison. वो अभी update करके relay बनाते रहते हैं. It's already in Harrison that you should mention a percentage transferrin saturation TSAT followed by serum ferritin, and then you should plan treatment of the patient. But initial treatment is oral iron for this chap. Okay. Next is a patient with salt wasting and salt craving. You know, this is a feature that you traditionally get with Addison disease, and moreover he is mentioned regarding the skin pigmentation aspect as well. So if you look at the language of the question, salt wasting, salt craving, hyperkalemia, you know the diagnosis in this patient. Answer would be option number A. Yeah, if oral iron was not there, I would have answered as erythropoietin. This is Addison disease, easy to pick. Then is anti-SCL70, that is anti-topoisomerase 1 antibody in systemic sclerosis, would be associated with development of ILD. Yes, guys, you can, yep. That would be increased incidence of interstitial lung disease in the patient. Fine, yeah. Previous one was Addison, then is ILD in the patient. Now we are going to talk about a guy with femur of the shaft fracture after road traffic accident. Internal fixation was done. There's a shortness of breast with confusion and petechial rash. So considering that there is a petechial rash that is also given, there is a CNS manifestation given, there's a shortness of breath that is given, major GERD criteria getting satisfied, and anytime if the GERD criteria are satisfied, the major ones, you will think in terms of fat embolism, you need one major and four minor criteria, though the minor criteria may be given in the question, but the major ones would help you identify this, and therefore the answer in this question would be given as option number A. एम्पेरिकल मतलब हमारे को अभी पता नहीं है कौन सा ऑर्गेनिज्म रेस्पॉन्सिबल है, पर हम ब्रॉड स्पेक्ट्रम ट्रीटमेंट दे देते हैं ना. एम्पेरिकल बेसिकली मीन्स दैट आई डोंट नो which is the organism responsible. It can be gram positive, it can be gram negative. So we give a broad spectrum coverage to the patient. CSF culture की report immediately तो आती नहीं. NEET PG 2024 was like eventful. There were two batches that were present. One was like morning batch, one was evening batch. So let's look at the evening batch first. Easy question. Young athlete underwent for competition and was found to have hypertrophic cardiomyopathy. Which of the following will increase the murmur in this question, murmur in this condition? This is again a question which I think was asked in 2022, 23, 24 again. So pretty straightforward. All murmurs will decrease with Valsartan standing amyl nitrate. Rationally is less blood will be coming in the heart, so murmur intensity will decrease. But hypertrophic cardiomyopathy is an exception to the rule. It is always gonna be like increase in intensity. So I would just like to highlight that with the respect to Valsartan स्टैंडिंग एंड अमाइल नाइट्रेट. सो VSA लिख रहा हूँ शॉर्ट में. वल्सावा हो गया, स्टैंडिंग हो गया, अमाइल नाइट्रेट हो गया. हाइपरट्रोफिक कार्डियोमायोपैथी का जो मरमर होता है वो लाउडर हो जाता है, और माइट्रल वाल्व प्रोलैप्स का जो मरमर होता है, MVP का जो मरमर होता है वो लॉन्गर हो जाता है. सो जस्ट टेक केयर ऑफ द फैक्ट all murmurs will decrease with Valsalva standing amyl nitrate, rationale being that less blood will be coming in the heart, so turbulence will reduce. The exceptions in the rule are hypertrophic cardiomyopathy and mitral valve prolapse with murmurs being longer and louder respectively. So the answer to this question is option number B. And then a question which was like very smartly designed. Patient came with shortness of breath. Only these much details were given. Heart rate was fast, BP was stable, and there was a diastolic collapse that was given. But couple of guys write diastolic collapse of atrium. Now in cardiac tamponade, we have diastolic collapse of ventricles, but prior to that, we have what is called as a low pressure cardiac tamponade. Guys, this particular question, which is a repeat from NEET PG 2024, is on low pressure cardiac tamponade because when the fluid will accumulate in the pericardial space, तो होगा क्या कि पहले तो वेंट्रिकल्स सीधा तो दबेंगे नहीं ना, पहले एट्रिया दबने शुरू हो जाएंगे, तो 30% ड्रॉप इन ब्लड प्रेशर हो जाता है बिकॉज एट्रिया कंट्रीब्यूट 30% ऑफ फिलिंग ऑफ ब्लड इन द वेंट्रिकल्स. तो होगा क्या कि मैं वेट थोड़ी ना करूंगा कि लो प्रेशर कार्डियक टैम्पोनेट जो है वो फिर कार्डियक टैम्पोनेट, वी डोंट यूज द वर्ड हाई प्रेशर कार्डियक टैम्पोनेट. We don't use the word high pressure cardiac tamponade. It is low pressure cardiac tamponade followed by cardiac tamponade. Low pressure cardiac tamponade का मतलब क्या होता है कि एट्रिया कोलैप्स कर रहे होते हैं और सब्सिक्वेंटली जैसे जैसे फ्लूइड का अमाउंट इंक्रीज होता है तो फिर वेंट्रिकल्स भी कोलैप्स कर जाते हैं. तो हम प्री एम्प्टिव एक्शन लेंगे, हम वेट नहीं करेंगे कि अनरिकॉर्डेबल बीपी हो जाए या सेरेब्रल इस्कीमिया हो जाएगा, ब्रेन स्टेम डेथ हो जाएगी. तो वी वुड लाइक टू गो इन फॉर अ पेरिकार्डियोसेंटेसिस फॉर दिस क्वेश्चन. आई वुड लाइक टू रिमाइंड यू दैट पल्सस पैराडॉक्सस इज नॉट प्रेजेंट इन लो प्रेशर कार्डियक टैम्पोनेट. सो बहुत सारे स्टूडेंट्स की कंप्लेंट यही थी कि इधर पल्सस पैराडॉक्सस तो दिया नहीं था, बीपी भी स्टेबल था, तो फिर आप कार्डियक टैम्पोनेट बोल कैसे रहे हो. तो भाई इको में दिख रहा है ना, पल्सस पैराडॉक्सस कोई रिलायबल फाइंडिंग थोड़ी ना है, वो तो प्रेगनेंसी में भी मिलती है, वो तो स्टेटस एस्थमेटिकस में भी मिलती है. और ब्लड प्रेशर क्यों स्टेबल है उसका मैंने रीजन बोला अभी कि अभी एट्रिया दबने शुरू हुए हैं तो आने वाले टाइम में बीपी क्रैश कर जाएगा. सो इट इज पेरिकार्डियोसेंटेसिस दैट शुड बी डन इन दिस केस. गुड जॉब गाइस. वी विल नॉट बी गिविंग बैलून, बेटा कार्डियोजेनिक शॉक में देते हैं ना. अगर इंट्रायोटिक बलून पंप तो तब देते अगर कार्डियोजेनिक शॉक में होता, तो उसका तो बीपी वैसे ही क्रैश होना चाहिए ना. इधर तो बीपी क्रैशिंग है ही नहीं है, तो इस वजह से इंट्रायोटिक बलून पंप का रोल नहीं है. एंड स्टार्टिंग अ डायूरेटिक विद बीपी मॉनिटरिंग, तो यहाँ पे क्या पल्मरी एडीमा दे रखा है नहीं ना. मतलब अगर इफ देयर वाज मेंशन ऑफ एक्यूट पल्मरी एडीमा, अगर यहाँ पे लिखा होता बायलैटरल बेसल क्रैपिटेशंस इन अ पेशेंट एंड लाइक बीएनपी इज ग्रॉसली एलिवेटेड, आई वुड हैव गिवन diuretics for the patient, but yep, on the basis of all the points I said, the answer is pericardiocentesis. फिर आसान ही था ये. ऑक्यूपेशनल ऑफ हाइपरटेंशन विद पैल्पिटेशंस और शॉर्टनेस ऑफ ब्रेथ. हार्डकोर क्वेश्चन, बायलैटरल बेसल क्रैपिटेशंस ऑन ऑस्कल्टेशन एंड एट्रियल फिब्रिलेशन. तो मतलब एट्रियल फिब्रिलेशन तो उसने बड़ी सारी कंडीशन मतलब क्वेश्चंस में डाल दिया था. There is atrial fibrillation, there is acute heart failure in a patient. The reason for this acute heart failure would be hypertension or hypertensive crisis, which could have explained this. And then he says like which of the following is least important in the management of this patient. So quick answers please. Okay. Start anticoagulants like warfarin in this patient. हाँ ये तो करेंगे, मतलब atrial fibrillation अगर पेशेंट में डॉक्यूमेंट हो रही है तो we will plan to start anticoagulants like warfarin. Makes sense in this patient. Which of the following is least important? Digoxin to control rate. Okay. गाइज ये क्वेश्चन गलत नहीं होना चाहिए था क्योंकि ये बहुत बार रिपीट करा गया हुआ है. बीटा ब्लॉकर्स आर कॉन्ट्राइंडिकेटेड. बीटा ब्लॉकर्स आर कॉन्ट्राइंडिकेटेड इन अ केस ऑफ एक्यूट हार्ट फेलियर. तो यहाँ पे बीटा ब्लॉकर नहीं देंगे, इसमें डिजॉक्सिन देंगे. मैंने बार बार इवन जो रिजॉल्व की क्लासेस थी उसमें भी बार बार एक्सप्लेन किया हुआ है, रैपिड रिविजन में भी हाईलाइट किया हुआ है कि जब भी बीटा ब्लॉकर एमसीक्यू में दिया होता है, ये अपना हैबिट बना लो कि जब भी बीटा ब्लॉकर किसी भी कार्डियो के एमसीक्यू में दिया होता है, कॉन्ट्राइंडिकेशंस फॉर हार्ट फेलियर, कॉन्ट्राइंडिकेशंस टू बीटा ब्लॉकर ABCD के फॉर्मेट में ना दियो. ए से एक्यूट हार्ट फेलियर, बी से ब्रोंकियल अस्थमा, COPD डायबिटीज मेलाइटिस है ना, और ब्रैडिकार्डिया ऑब्वियसली. तो एक्यूट हार्ट फेलियर में हम बीटा ब्लॉकर्स नहीं देते हैं. दैट इज व्हाई द आंसर इन दिस क्वेश्चन वुड बी ऑप्शन नंबर बी. बाकी ऑब्वियसली कार्डियोवर्जन तो देंगे अगर हेमोडायनेमिकली अनस्टेबल रहता है. हम इन पेशेंट रिमेन्स हेमोडायनेमिकली इवन आफ्टर मेडिकल मैनेजमेंट. एंड या इन दिस कंडीशन हम क्या करेंगे, डिजॉक्सिन दे देंगे क्योंकि डिजॉक्सिन तो हार्ट फेलियर में भी काम करेगा और वेगस एक्टिविटी को भी एक्टिवेट करेगा. भाई इट हैज अ पॉजिटिव आइनोट्रोपिक एक्शन, सो इट विल गिव यू बेनिफिट इन मैनेजमेंट ऑफ हार्ट फेलियर. सो व्हाई एम आई यूजिंग डिजॉक्सिन? इट विल ट्रीट माई हार्ट फेलियर. And it also will be having a vagus activation. Because of that vagal activation, it will be able to control the ventricular rate in this patient. So at this moment, the answer in this question would be option number B. That is beta blocker, which can be given for this patient. So I think we are sorted. Now is भाई यूजर ज्यादा हो जाता होगा किसी टाइम पे, इस वजह से स्लो हो जाती होगी, है ना। तो इंटरनेट पे तो ऐसे ही है ना, जीमेल चलता है तो कहते हैं बहुत अच्छा, नहीं होता तो सब बोलते हैं अरे यार इट सक्स। ओके, व्हाट इज द मोस्ट कॉमन कॉज ऑफ डेथ इन इडियोपैथिक पल्मरी फाइब्रोसिस, आईपीएफ में व्हाट इज द लीडिंग कॉज ऑफ डेथ? तो रेस्पिरेटरी फेलियर तो होना ही होना है, right? And then pulmonary artery hypertension is a complication that would be developing in this patient. Yes, guys, when the question came, people were stuck between two things. One was respiratory failure, and then is obviously that pulmonary artery hypertension. But like the lungs will begin to fail, the lungs will begin to shrink. In fact, Pandit Zakir Hussain, one of the leading tabla exponents of India, he went to US. He died in a couple of years back in United States for pending a lung transplantation. So the main reason why these patients will be dying is because of respiratory failure, because the lungs will basically shrink and therefore the oxygen saturation will begin to drop. The complication of that hypoxia, that is respiratory failure, would be a pulmonary artery hypertension. So between two close options, pulmonary artery hypertension, respiratory failure, main karan kya hai death ka? To it is respiratory failure, and the complication that can develop in these patients is pulmonary artery hypertension. Okay, patient comes with acute epigastric pain and increase in the serum lipase levels. So the moment I say epigastric pain increases serum lipase levels, I'm talking about acute pancreatitis. And the moment I say acute pancreatitis in a patient, and then after stabilization, you can notice that both the lung fields of the patient are showing like extensive pulmonary edema. So the guy has gone into a complication, that is acute respiratory distress syndrome. That would be a non-cardiogenic pulmonary edema developing in this patient. This is, I mean, ARDS is the complication. He was given fluids maybe for stable conservative management would have been done for pancreatitis, but then the lungs are showing evidence of non-cardiogenic pulmonary edema at the moment. So yep, the answer in this question, no, but we would not like to call it a bat wing sign at the moment, because cardiogenic nahi hai na, non-cardiogenic है. Bat wing जो word होता है, that is for the cardiogenic varieties. So this would be acute pancreatitis, and then ARDS as a complication that has occurred in this case, so non-cardiogenic pulmonary edema. Yep. Then is a patient who had come with multiple episodes of GTCS. The MRI head is shown below, and then you can see a ring enhancing lesion, lot of cerebral edema that is present in this patient. So it's obviously neurocysticercosis, but then one of the differentiations or a differential that needs to be kept is always a tuberculoma. And considering the fact that there are two close differentials which are to be taken, though evidence wise this looks as neurocysticercosis with the scolex that is present, we would like to go for a yep, it is tuberculoma. So the correct answer would be a spectroscopy for diagnosis of this condition. Exactly, that would help you in identification. So he did not even get into like tree halos elevation or like amino acid peak would be present. Like tree halos is a sugar, and then lipid, like if the question specially mentioned tree halos and lipid peak, it goes in favor of a tuberculoma. Amino acid peak, that goes in favor of neurocysticercosis. So it did not even get into it. And functional MRI is what you do in conditions like Alzheimer's disease. PET scan again is useful for identification of Alzheimer's. So I mean those are like functional scans which would be available. Then is a ECG based question where you can notice that there is a variation in the height of the broad QRS complexes. You can see the broad QRS complexes, and each one of them, the height is changing. So this is a polymorphic ventricular tachycardia. Polymorphic ventricular tachycardia can be seen with macrolides in combination with antihistaminic drugs, that is like estamizole. So the correct answer in this question is option number A. Acute heart failure कहाँ से पता चला इसमें? एक्यूट हार्ट फेलियर कहाँ से पता चला? ओके ओके, इस वाले क्वेश्चन का पूछ रहे हो शायद, बायलैटरल बेसल क्रैपिटेशंस ना, आई थिंक वो रिले धीरे चल रहा होगा किसी का, बायलैटरल बेसल क्रैकल्स ऑन ऑस्कल्टेशन ना, तो वहां से पता चला ना एक्यूट हार्ट फेलियर प्रेजेंटेशन है. बायलैटरल बेसल क्रैपिटेशंस आर अ फीचर दैट यू सी इन पेशेंट्स ऑफ हार्ट फेलियर ना, तो हार्ट फेलियर में फिर हम बीटा ब्लॉकर नहीं देते. ओके Okay, so cisapride, then estamizole, terfenadine, those are a couple of drugs like which can cause prolongation of QT interval. I mean, the main risk factor in this case is all of these would cause a prolongation of QT interval. So answer to this question is option number A. Then is a patient who presented with features of right heart failure and exhibits a blunted wide descent on a cardiac examination. What is the most likely diagnosis? Azithromycin is less likely to contribute to it. It's mainly erythromycin, which is like notorious to contribute. Waiting for your answers for the next question. There is a blunted Y descent in a patient. भाई पढ़ लो ध्यान से, blunted Y descent लिखा हुआ है, मतलब it is not a absent Y descent ना, it is a blunted Y descent in a patient, which will change the answer in this question to that of tricuspid. यार cardiac tamponade में तो absent Y descent होगा ना, it would be an absent Y descent. Y descent पे 3 क्वेश्चन बनते हैं, आप गलत कर रहे हो. अगर मैं यहाँ पे बोलता steep Y और steep X तो आपको पता ही है, then it is constrictive pericarditis. If I said absent Y, then it would be cardiac tamponade. And if I say the word blunted Y descent, then I will say tricuspid stenosis in a patient. Obviously steep X तो यहाँ दोनों में ही common है. Steep X is common between both of them, so that's okay. But then in tricuspid stenosis, you would be having is a blunted Y descent present. So the answer in this question would be option number C. Yep. You guys are brilliant chaps, you're doing great. बस वो जल्दबाजी में मत आंसर करो ना कि बस पढ़ लिया तो सही हो गया. चलो कोई बात नहीं, हो जाता है कभी कभी तो, एक दो तो होती हैं गलतियां. जो तुम्हारा गलत हुआ और राइवल का नहीं होगा, उल्टा भी हो जाता है. चलो. PR interval was measured at 0.21 seconds, which is slightly in excess of what is normal, but there's no mention of any dropped beats, and it's a corporate executive, like maybe come for a regular medical checkup. So in this case, the answer would be given as first degree heart block. Yep. The answer in this question is option number B, that is first degree heart block. Then is an alcoholic patient with a 10-day history of binge drinking with altered sensorium, slurred speech and unconsciousness. Blood glucose was pretty low. And yeah, I'm thinking in terms of Wernicke's encephalopathy for this patient. So I would like to give thiamine followed by dextrose infusion in a patient. The answer in this question is relatively easy, but I would just like to put a word of caution here कि ऐसा ना हो कि unconsciousness in a alcoholic patient पे सीधा आप हमेशा Wernicke's encephalopathy ही consider करो. Unconsciousness in alcoholic patient can also be a presentation of hepatic encephalopathy. तो देख लेना कि ऐसा ना हो कि क्वेश्चन में एस्टरिक्सिस जैसा मैनिफेस्टेशन लिखा हो, एप्रैक्सिया लिखा हो, ऑल्टर्ड स्लीप पैटर्न लिखा हुआ हो, क्योंकि फिर आंसर चेंज हो जाएगा. क्योंकि यहाँ पे फिर हम जो देंगे उसको वो लैक्टोलोज देंगे. लैक्टोलोज के साथ में इसको दिया जाएगा फ्रेश फ्रोजन प्लाज्मा और साथ में ऑब्वियसली इसको दिया जाएगा आईवी डेक्सट्रोज. सो डू टेक केयर ऑफ द फैक्ट दैट देयर हैज बीन अ क्वेश्चन इन द पेपर where unconscious alcoholic was given and the question was on the topic of hepatic encephalopathy, that is like manifestations were described for it, and then on those aspect the answer would be given as intravenous thiamine infusion followed by dextrose. So it is unconscious alcoholic, that's the word to be taken care of. Okay, फ्रेम रेट ड्रॉप हो रहा था तो मैं जरा चलो इलॉन मस्क को मुझे बोलना पड़ेगा कि भैया स्टारलिंक फटाफट से दे दो. रिफ्रेश कर लो, रिफ्रेश कर लो. हाँ हाँ यार, वो बीच बीच में तो अब क्या कर सकते हो, तो सरकार जो है वो जैसा इंटरनेट एयरटेल वाला देगा उसी को. रिफैक्सिमिन इज बेसिकली अ बैक्टीरियोस्टैटिक. Rifaximin is a bacteriostatic antibiotic that can also be used in a patient. So yeah, I mean your point is right. I mean मैं यहाँ पे R भी mention कर रहा हूँ, RX लिख रहा हूँ. Rifaximin would also be given in this case. Okay, I'll repeat the point once again. Unconscious alcoholic, if he comes and then he gives you a scenario where patient was having altered sleep pattern, he was having euphoria initially, he was having asterixis. एक बार कोमा हो गया फिर तो मतलब asterixis का सवाल ही नहीं है. But prior to that, the patient was having impaired visuospatial skills, he was having altered behavior, घर वालों को पहचान नहीं रहा था. So if that information is given for a bizarre behavior, then even hepatic encephalopathy should be considered. And in those circumstances, यार आवाज नहीं आ रही भाई, रिफ्रेश करो. साउंड चेक, साउंड चेक. एक बार मैं अपना देखता हूँ भाई. आ रही है यार, आ रही है, मेरी में आ रही है. ठीक है, फाइन. So the point I wanted to say, I'll say this point once again. In any unconscious diabetic, don't assume that it is always a presentation of Wernicke's encephalopathy, and do take care of the possibility of hepatic encephalopathy as well. So if he mentions bizarre behavior, asterixis, apraxia, euphoria initially and then progressing to inability to recognize family members. And if he mentions serum ammonia levels are elevated, it becomes blood ammonia levels are elevated, it makes it all the more easier for you. So Lola will not be very great for management because I want to take care of the lactulose component, I want to take care of the bleeding component and falling blood sugar. So yeah, I mean your point is right, but that would not be a priority intervention that I'll be doing. The answer to this question is option number A, and we move to the next one. What is the next best step in the management of a pulseless patient? Lola will not be next best step in the management of a pulseless patient with the following rhythm. ऑप्शन बी विटामिन के फॉलोड बाय डेक्सट्रोज. बेटा विटामिन के काम नहीं करेगा ना, विटामिन के काम ही नहीं करेगा बिकॉज अगर आप हेपेटिक एंसेफेलोपैथी में विटामिन के देते हो तो लिवर के सेल तो डिस्ट्रॉय हो गए ना. तभी तो मैंने बोला क्या देते हैं, फ्रेश फ्रोजन प्लाज्मा. देयर इज नो रोल ऑफ विटामिन के व्हेन द liver is damaged in a patient. So intravenous vitamin K in a liver patient will, I mean देते हैं clinical practice में, but असर तो नहीं करेगा ना. Textbook says give one dose of vitamin K and see if the bleeding gets controlled because some hepatocytes would still be present functioning, but then actually में तो majority of hepatocytes are destroyed in hepatic encephalopathy, so it's like playing with fire and fresh frozen plasma would be recommended. Okay जी. Next best step in management for pulseless patient with the following rhythm. So pulseless patient मतलब pulseless electrical activity के फेवर में ही जा रहा है. And pulseless electrical activity जब भी आप कंसिडर करोगे, ओके पल्सलेस पेशेंट, नो नॉट अ पल्सलेस इलेक्ट्रिकल एक्टिविटी. इनफैक्ट वो रिदम इसमें स्पेसिफाइड होना चाहिए. चलो मैं रिदम को मेंशन कर देता हूँ. द रिदम मोस्ट ऑफ द टाइम विल बी इन द फॉर्म ऑफ अ वेंट्रिकुलर फिब्रिलेशन और वेंट्रिकुलर टैकीकार्डिया, राइट. सो द क्वेश्चन इज नॉट ऑन पल्सलेस इलेक्ट्रिकल एक्टिविटी, इट कुड बी वेंट्रिकुलर फिब्रिलेशन और वेंट्रिकुलर टैकीकार्डिया फॉर अ पल्सलेस पेशेंट. देन इट इज डिफिब्रिलेट एंड कंटिन्यू द चेस्ट कंप्रेशंस इन अ पेशेंट. बट अगर मैं इसको चेंज कर दूं पल्सस इलेक्ट्रिकल एक्टिविटी, कमेंट करना चैट बॉक्स में फटाफट से. इन अ पल्सस इलेक्ट्रिकल एक्टिविटी सबसे पहले क्या करेंगे? If the question was, yeah, it is first epinephrine ASAP. If the question was on pulseless electrical activity, then it is epinephrine as soon as possible, epinephrine ASAP, and then subsequently obviously that chest compressions at a ratio 30:2 would be given. If I remove the word ASAP, that is as soon as possible, from the discussion, then obviously the answer will become CPR for management of this patient. But yeah, any pulseless patient with a defibrillation, it is defibrillation and continue the chest compressions in the patient. Okay. This question was out of syllabus in a sense that it is not given in Harrison and I had to look it up. But it can be understood like this कि अगर 10% बीटा सेल्स डिस्ट्रॉय हो जाते, इमेजिन करो कि सिर्फ पैंक्रियाज में 10% बीटा सेल्स डिस्ट्रॉय हो जाएंगे, तो पेशेंट में ऑब्वियसली ऑटो एंटीबॉडीज तो हैं, एंटी आइलेट सेल एंटीबॉडीज प्रेजेंट होती हैं. तो एंटी आइलेट सेल एंटीबॉडीज ने 10% बीटा सेल्स को डिस्ट्रॉय कर दिया, तो अभी ब्लड शुगर भी नॉर्मल रहेगी और पेशेंट एसिम्प्टोमेटिक रहेगा. लेकिन अगर अज्यूम करो 50% बीटा सेल्स डिस्ट्रॉय हो जाते हैं, 50% अगर बीटा सेल्स डिस्ट्रॉय हो जाएंगे तो सिम्टम्स नहीं आएंगे, बट पेशेंट विल स्टिल रिमेन डिसग्लाइसीमिक, मतलब शुगर बढ़नी उसकी स्टार्ट हो जाएगी. लेकिन इमेजिन करो कि 90% बीटा सेल्स अगर किसी के डिस्ट्रॉय हो जाते हैं तो फिर तो सिम्टम्स भी आने शुरू हो जाएंगे और साथ में उसका शुगर का वैल्यू भी सिग्निफिकेंटली एलिवेटेड हो जाएगा. एंटीबॉडी सभी में पॉजिटिव रहने वाला है. सो हियर गिवन परम्यूटेशन कॉम्बिनेशंस फ्रॉम द पर्सपेक्टिव ऑफ व्हाट इज सीन इन टाइप 1 डायबिटीज mellitus stage 3. So stage 3 would basically mean that obviously there would be dysglycemia that is present in a patient, but then the main point is yep, I'm just waiting. हाँ वो रेंज है 70 to 90%. तो मैं ऐसे नहीं बोलूंगा, देखो मतलब ऑब्वियसली द पेशेंट विल नॉट बी एसिम्प्टोमेटिक, तो मतलब एसिम्प्टोमेटिक वर्ड तो बाहर ही हो जाता. नाउ इट इज बिटवीन ए वर्सेस बी वर्सेस सी इन द पेशेंट. तो आई मीन सी भी नहीं हो सकता, नॉर्मल ग्लाइसीमिक है, तो या तो सिम्प्टोमेटिक हाइपरग्लाइसीमिया बेस्ट वर्ड रहेगा या फिर डिसग्लाइसीमिक सिम्प्टोमेटिक इन अ पेशेंट. सो बी भी आ रहा है. इट्स नॉट दैट यू आर रॉन्ग डॉक्टर, इट्स नॉट दैट यू, आई मीन लाइक explain A. Yeah, like I would like to say like this, that we have to go by technical terminology in this question, like symptomatic hyperglycemia, not a very technical way of describing the information. I appreciate the fact that both option number A and option number B technically would mean the same only. But if we go by the definition that is given, dysglycemia implies that there is a high blood sugar in a person and then there are presence of symptoms in the patient also. So either it will be A or it will be B only. I appreciate your point. When I say A or B, they basically mean the same only, but we have to go by the technical definition that is given. So it would be a symptomatic patient and it would be dysglycemia that would be present in the person. So answer to this question is option number B. And don't worry, I mean, this is a research based question that came, and 1 to 2 such questions will always be there. And I don't think so that we need to worry too much about it. When rhythm present, why defibrillate? When rhythm present, in which one? No, doctor. In that following rhythm, no, that ECG was given of ventricular fibrillation with the following rhythm disorder, right? Was a rhythm disorder. The word is not rhythm. There was a rhythm that was given in the question. That's why. Okay, so we leave them. Absolutely, you have to leave them. You don't have to score 100%. No, that is why you don't want to increase your negative marks. Dysglycemia. Not exactly. Okay, fine. I buy your point. I buy your point on the same, and we can argue the whole night about it. But I would not like to be drawn into a unnecessary controversy, which will not yield in anything. So, a technical answer would be still a dysglycemia. Okay. We are having a patient who's having acidosis. Now, when you check it out, this acidosis is giving you a big report where pH is less, bicarbonate is also less. There is no mention regarding the PCO2. So, because pH is less and bicarbonate is less, it is metabolic acidosis. Yep. In this particular question, the main hint is there is a hypoglycemia component. Because of hypoglycemia, it cannot be renal tubular acidosis type 4. वो तो बाहर ही हो गया. टाइप 3 होता नहीं है, तो टाइप 1 और टाइप 2 के बीच में ही हमें आंसर करना है. It is urinary pH of 9.4. I have explained to you that if you are not able to acidify the urine, मैं लिखता हूँ इसको, maybe a lot of guys are getting it wrong. If I say the word inability to acidify the urine, if I say the word inability to acidify the urine, that means that there would be a urinary pH of more than 5.5. And the moment I say urinary pH more than 5.5, it rings a bell. You remember it is renal tubular acidosis type 1. Exactly. Because यहाँ पर हो क्या रहा है कि आप हाइड्रोजन को एक्सक्रीट ही नहीं कर पा रहे. कॉन्सेप्ट क्या जा रहा है, अ लॉट ऑफ स्टूडेंट्स हियर फेल फॉर द ट्रैप. उन्होंने बोला कि बाइकार्बोनेट इन द यूरिन की वजह से देयर वुड बी अल्कलाइन यूरिन इन आरटीए टाइप 2. लॉजिकली तो ऐसे ही मैंने बोला ना, बाइकार्बोनेटूरिया इज अ फीचर ऑफ आरटीए 2 बिकॉज बाइकार्बोनेट इज लॉस्ट इन द यूरिन. बट होता क्या है कि बाइकार्बोनेट सारा का सारा बॉडी से निकल जाता है, तो लेटर स्टेजेस ऑफ आरटीए 2 में देयर इज नो बाइकार्बोनेटूरिया बिकॉज देयर इज अ सिवियर एसिडोसिस एंड डिप्लीशन ऑफ बाइकार्बोनेट इन द बॉडी. तो अल्कलाइन पीएच नहीं होता है, यूरिन पीएच इज रादर लेस देन 5.5. I'll say the point once again. In renal tubular acidosis, bicarbonate is present, but bicarbonate कम होके bicarbonate खत्म हो जाएगा बॉडी में, and then there's a severe bicarbonate depletion. So the urinary pH in the patient will be remaining less than 5.5. That's the main differentiating feature between the two. In this particular question, the logic to be used is first, hypokalemia is found in only two types of RTA, RTA1 and RTA2. RTA4 तो हो नहीं सकता. And between RTA1 and RTA2, what you have to click in that 30 seconds in the MCQ is the urinary pH values. If the urinary pH values in the patient are more than 5.5, because keyword क्या है, alpha intercalated cells are defective, you cannot acidify the urine. तो जब हाइड्रोजन एक्सक्रीट ही नहीं हो पाएगा तो यूरिन अल्कलाइन रहेगा, तभी तो ब्लड एसिडिक हो रहा है ना. So the answer in this question is option number A. And the hack behind this question I'll say once again is पहले पोटेशियम देख लो, अगर एलिवेटेड होता तो RTA4 हो जाता. हाइपोकलीमिया फाउंड इन RTA1 एंड RTA2, और दोनों में डिफरेंशिएट करने के लिए यूरिन पीएच को चेक करना है. यूरिन पीएच इज मोर देन 5.5 in RTA1. The rationale is inability to acidify the urine. RTA3 doctor is not present or is very rarely seen, so उसके बारे में डिस्क्रिप्शन बुक्स में दिया ही नहीं होता. It is only research papers that are given. So it is RTA1, 2 and 4, only the three varieties which are to be remembered by you. Okay, so we are sorted for the ones which are currently explained at the moment. What is the expected finding in a patient with the following chest x-ray? Okay, so I think we are missing the image in this case. The chest x-ray was okay, so I'll explain this. The chest x-ray in this patient was showing fracture of multiple ribs. I think I missed out in the image here, maybe while I was converting the PDF that did not come. So you guys can quickly mention regarding this. There's a fracture of ribs in a patient, so I think that makes it all the way easier. Fracture of ribs, they would be flail chest, and flail chest would mean that there would be paradoxical breathing that would be present. So the answer to this question will turn out to be option number B. Anyway, I mean, they'll give you a trauma case and you'll be able to answer it. If I change this and if I talk about CNS damage in a person, then it can be apneustic breathing. If it's gonna be a pneumonia, then it is gonna be bronchial breathing that is present. Apneustic breathing is that prolonged inspiratory spasms. Prolonged inspiratory spasm that is seen with respect to brainstem stroke in a patient. And for small breathing is standard, that would be diabetic ketoacidosis. Okay, let's look at the morning batch now. The patient was having complaints of headache and confusion. A brain tumor diagnosis is made, and the family history reveals brain and kidney tumors. So when you read about like brain tumor, kidney tumor in a patient, you know the main aspect to be thought of is von Hippel-Lindau syndrome. Suppose in this question there was a modification that was present. The modification would have been with respect to brain tumor with breast sarcoma and adrenal tumor. Then we'll think in terms of Leaf-Remini. So the answer in this question is pretty straightforward. It would be given as option number C. And yeah, I mean, the highlight of this condition would be a brain tumor, that is a cerebellar hemangioblastoma. And when I say cerebellar hemangioblastoma, the highlight is it is not originating from the cells of the cerebellum, because normally in the cerebellum you have Purkinje cells, basket cells, granular cell, Golgi cells. So this would be a cerebellar hemangioblastoma. And when I look at that hemangioblastoma, it's originating from the blood vessels in the brainstem of the patient. So that's why related to chromosome number 3. Exactly. Next was a question which was regarding left-sided arm and a leg weakness in a patient. So I'll just draw a crude diagram like this. In the paper, you just have to mentally visualize left-sided arm weakness and a leg left and arm weakness and right-sided facial paralysis. So first thing first is that this is a brainstem stroke, because brainstem stroke would always be crossed. So there is a right-sided facial nerve palsy that is occurring in this patient. That tells you that either the answer will be Fowell syndrome or it will be Millard-Gubler syndrome. Wallenberg is ruled out in this case because Wallenberg would be the involvement of cranial nerves like 5, then it would be 7, 9, 10, that would be involved. Even the 8th one also. When it comes to Benedict syndrome, it would be the 3rd cranial nerve that would be involved along with basal ganglia. So I'm ruling that out also. Between Fowell syndrome and Millard-Gubler syndrome, there is a mention of conjugate gaze palsy. The highlight on this question is, was it written the word only lateral gaze weakness or conjugate gaze palsy? Conjugate gaze palsy means that the 6th nerve nucleus is getting affected. The highlight of this question is कि यहाँ पे 6th nerve का न्यूक्लियस इन्वॉल्व हो रहा है, क्योंकि 6th nerve का न्यूक्लियस विल बी डूइंग अ क्रॉस टॉक विद द 3rd nerve का न्यूक्लियस, जिसकी वजह से कंजुगेट गेज होती है, एंड यू कैन मूव बोथ योर आइज टुवर्ड्स राइट एंड बोथ योर आइज टुवर्ड्स द लेफ्ट. सो बिकॉज ऑफ द क्वेश्चन देयर इज इन्वॉल्वमेंट ऑफ द 6th nerve nucleus in a patient. That is the main thing that is to be affected. That's the main point to be picked up, that there would be a conjugate gaze palsy that is involving in this patient. 5th तो यार हो ही जाता ना, 5th would be getting involved in a patient. यहाँ पे थोड़ा नंबर्स मॉडिफाई कर देता हूँ मैं उसके. आई मीन वैलेनबर्ग सिंड्रोम प्राइमरली जो 5th तो इन्वॉल्व होना ही होना है, राइट? And then would be 9, 10th and the 11th, and like even some component of 8th can come in the question. So 5, 8, 9, 10, 11 are the ones which would be involved in. Yeah, Wallenberg would be mainly 9, 10, 11, but 5 and 8 also get involved in Wallenberg syndrome. So just modified that. And Fowell syndrome may it would be 6 and 7. 6 and 7, not the 8th one. It is not the 8th. It is 6th and 7th. Millard-Gubler syndrome, whenever I say it is gonna be always having the word lateral gaze weakness. If the question says lateral conjugate gaze palsy, the word palsy comes in, then your answer would be given as Fowell syndrome. The answer to this question would be given as option number A. बेटा 12th नहीं होगा ना, 12th के लिए तो आपको बताया हुआ ना medial medullary syndrome होता है, तो उसमें 12th तो आनी नहीं है. So the answer to this question is option number A. Okay, a CKD patient has a tachycardia and then the ECG of the patient was done. You could pick up the T waves which are spiking. So you know that the electrolyte imbalance in this case would be that of hyperkalemia. Most guys were able to solve because CKD में होना ही hyperkalemia वाले manifestations होते हैं. But yeah, when you treat the patient, you give diuretics so that diuretics can result in hypokalemia. Like suppose if the CKD patient came on with very severe decrease in urine output, it was acute kidney injury on CKD. then we give furosemide and that can cause a hypokalemia component, or if we give thiazides to the patient, they can also cause an hypokalemia on treatment, but the initial presentation will always be a hyperkalemic metabolic acidosis. So answer in this question is option number A. Then is that person with large sweaty hands, macroglossia and frontal bossing. So immediately what comes to your mind is Khali, the great WWE star, and we are talking about acromegaly. And what is the best test for confirmation or diagnosis? So if we say screening test, then it is IGF-1. But to check for confirmation or diagnosis, we would like to go for glucose challenge test in a patient, where I would like to mention the values of growth hormone after glucose suppression. So therefore the answer in this question would be growth hormone levels after glucose suppression. Normally, like, the growth hormone levels are bound to get suppressed after administration of glucose, but in this guy, because it's after all a tumor, the tumor will not respect physiology and the levels of glucose will remain elevated. Good job, guys. Then is a patient with Wilson disease presenting with neurological manifestations. What is the best diagnostic modality? We can do a PCR in the patient for genetic mutations, but then at the same time, the traditional way for diagnosis would be a hepatic copper content, because it would be a liver biopsy with estimation of hepatic copper content. And before we do a liver biopsy, we must check the coagulogram. We must bring the coagulogram before come back to normal before any liver biopsy is attempted in any patient with liver disease. Obviously, because I don't want to take up the risk of between PCR and biopsy, it is biopsy that would be answered as the gold standard according to the textbook, or the best test for diagnosis, because quantification karna hai. It is the quantification which is to be done. First line management for dangerous hyperkalemia. Yeah, dangerous hyperkalemia depends ना, acute है कि chronic है. Chronic है तो हम सिर्फ chelators दे देते हैं. We give novel potassium binding agents, and if it's gonna be acute, then we first give calcium gluconate and then give insulin drip in the patient. Okay, next is an asthmatic in whom the FEV1 is increasing. एक क्विक अपडेट बोल देता हूँ कि अगर वो बोलता है कि एस्थमा के डायग्नोसिस के लिए FEV1 का इंक्रीमेंट कितने परसेंट से ज़्यादा होना चाहिए, तो मैंने आपको हमेशा 12% बताया है. वो 12% अभी भी करंट एडिशन में दे रखा है, लेकिन जो करंट एडिशन है हैरिसन का 22nd का, उसमें उसने मेंशन किया है कि 10% शुड बी टेकन एज अ कट ऑफ टू इंक्रीज द डायग्नोस्टिक एक्यूरेसी. तो एक बस अपडेट याद कर लेना, छोटा सा अपडेट है, ऐसा नहीं कि कोई नई चीज़ बता रहा हूँ, कोई बहुत ज़्यादा एफर्ट की बात नहीं है. दैट इफ ही स्पेसिफिकली मेंशंस द फैक्ट दैट what should be the increment in FEV1 after giving albuterol challenge to the patient, then the FEV1 should be increasing by more than 10%. Otherwise traditional 12% वाला भी हैरिसन में दोनों लिखे हुए हैं. वो बोलता है टू इंक्रीज द डायग्नोस्टिक एक्यूरेसी, क्योंकि अभी AQI प्योर हो गया मोस्ट कंट्रीज में पोल्यूशन की वजह से, इंडस्ट्रियलाइजेशन की वजह से. सो वी वांट टू पिक अप द डिजीज अर्ली. सो इस इज द एडिशनल डेफिनेशन की वजह से हमने थ्रेशोल्ड को कम कर दिया. Now, what will you do in this patient is give steroids in a patient, add inhaled corticosteroids. And as far as the algorithm is concerned, हम पहले उसको देते हैं लो डोज इनहेल्ड corticosteroid, फिर देते हैं मीडियम डोज स्टेरॉइड, फिर हाई डोज नहीं देते हैं. वी गिव बायोलॉजिकल्स टू द पेशेंट. ये आज भी किसी ने मुझे मैसेज किया था कि हम हाई डोज क्यों नहीं दे रहे. तो हाई डोज स्टेरॉइड्स कंट्रीब्यूट टू एड्रेनल सप्रेशन. ऐसा नहीं होता कि स्टेरॉइड्स देने से कुशिंग सिंड्रोम नहीं होता. हाई डोज इनहेल्ड दे रहे हो लेकिन कुशिंग सिंड्रोम तो होता है. हाइपोथैलेमिक पिट्यूटरी एक्सेस इनसफिशिएंसी भी होती है. सो इट इज लाइक इट इज लो डोज, इट इज मीडियम डोज, एंड देन वी कंसिडर biologicals in a patient, and high dose is not recommended because of the risk of adrenal suppression. तो करना क्या है, we will be giving lama in the patient. मैं एक बार पॉइंट लिख देता हूँ. पहले हम दे रहे होते हैं लो डोज इनहेल्ड कॉर्टिकोस्टेरॉइड, फिर लो डोज के बाद में एस्केलेशन जो थेरेपी होती है वो होती है मीडियम डोज इनहेल्ड कॉर्टिकोस्टेरॉइड. उसके बाद एस्केलेशन थेरेपी होती है इट इज लामा टू बी एडेड इन द पेशेंट, और उसके बाद में लिखा होता है प्लस माइनस यू कैन कंसिडर बायोलॉजिकल थेरेपी इन द पेशेंट. सो दैट इज अ अपडेट विच इज दैट इज नॉट एग्जैक्टली एन अपडेट, ये यही रहा है, बट लाइक इट इज जस्ट कि अभी उसको वो अपडेट के फॉर्म में ज्यादा लिखना शुरू कर देते हैं. सो इट इज लो डोज इनहेल्ड कॉर्टिकोस्टेरॉइड, इट इज अ मीडियम डोज इनहेल्ड कॉर्टिकोस्टेरॉइड. इफ देयर इज स्टिल नो इंप्रूवमेंट देन द एस्केलेशन वुड बी कि आप यहाँ पे ऐड कर दोगे लामा, एंड टू दैट यू विल बी एडिंग biologicals for management in this patient. ओके, वो जो आप बोल रहे हो ना निकिता, दैट इज अ पॉइंट दैट इज फॉर COPD. आप जो बोल रहे हो डॉक्टर निकिता, दैट पॉइंट इज टू बी फॉर COPD इन अ पेशेंट. वो इसके लिए नहीं है, वो गोल्ड वाली क्लासिफिकेशन आप मिक्स कर रहे हो. आप एक बार रिजॉल्व का फोल्डर फिर से खोलना और उसमें चेकआउट करना. मैंने जो स्पूटम इस्नोफिल्स या ब्लड इस्नोफिल्स में मैंने बोला है कि ब्लड इस्नोफिल्स मोर देन 300 वाला वैल्यू है, दैट इज फॉर COPD मैनेजमेंट. आप उसके साथ मिक्सअप मत करो. Okay, so just a word of caution there. Patient comes with acidosis and all the three values are less, so it is obviously a metabolic acidosis. Yes guys, I can expect quick answers for this one. Mathematics कर लेते हैं. 136 minus 110, that would be 26 minus 6, 20. So an gap is more, so high in gap metabolic acidosis. Yes, yes. यहाँ पे एक आ रहा है विद रेस्पिरेटरी एसिडोसिस. तो आपने देखना है ना यार यहाँ पे कि आप यहाँ पे एक्चुअल PCO2 को कंपेयर करना है ना. द एक्चुअल PCO2 और एक्सपेक्टेड PCO2 को आपने कंपेयर करना होता है. अगर एक्चुअल PCO2 की वैल्यू इज मोर देन दैट ऑफ द एक्सपेक्टेड PCO2, देन इट विल बी अ मिक्स्ड डिसऑर्डर. मिक्स्ड के लिए जो क्राइटेरिया आपको बताया हुआ है वो है कि जो एक्चुअल वैल्यू होती है, इफ इट टर्न्स आउट टू बी हायर देन द एक्सपेक्टेड PCO2, इट इज अ मिक्स्ड डिसऑर्डर. But if the actual PCO2 of the patient is equal to or is less than the expected PCO2, it will be compensation in the patient. हाँ, 15 प्लस 6 करोगे तो 21 आएगा ना. 15 प्लस 6 करोगे तो 21 आएगा. तो यहाँ पे तो वैल्यू आ रही है 13 की, तो इसका मतलब तो ओवर कॉम्पेंसेशन होगी ना. डायफ्राम बहुत अच्छे से काम कर रहा होगा पेशेंट का, तो ओवर कॉम्पेंसेशन होगी. इफ द वैल्यू इज मोर देन द एक्सपेक्टेड गाइज, इसको ध्यान रखना, अपने माइंड में इसको इम्प्रिंट कर लो अगर ये क्वेश्चन गलत हुआ है तो. इफ द एक्चुअल PCO2 इज मोर देन द एक्सपेक्टेड PCO2, देन यू कॉल इट अ मिक्स्ड. बट इफ द वैल्यू इज टर्निंग आउट टू बी इक्वल or it is lesser, then it will be answered as compensation. This point has to be remembered for all the questions that come on the topic of metabolic acidosis in the paper. Formula, that formula is 15 plus the value of bicarbonate ना. कैसे एक्सपेक्टेड कैसे निकालते हैं दो, अभी आज तो मतलब वी शुड नॉट बी डिस्कसिंग कि कैसे निकालते हैं, मतलब वी हैव पास दैट स्टेज. बट एनीवे इट इज जो भी बाइकार्बोनेट की वैल्यू दे रखी है ना उसमें 15 जोड़ दो. तो अगर 15 प्लस 6 करते हो तो 21 आना चाहिए. इसमें 13 है तो इट्स रनिंग आउट टू बी लेसर. दैट मीन्स कॉम्पेंसेशन इज वर्किंग इन दिस पर्टिकुलर केस, एंड देयरफॉर द करेक्ट आंसर फॉर दिस वन वुड बी ऑप्शन नंबर बी. जो भी बाइकार्बोनेट की वैल्यू उसमें 15 ऐड कर दो. अगर वो वैल्यू मोर आती है दैट इज मिक्स्ड डिसऑर्डर. मतलब एक्सपेक्टेड की जो वैल्यू है और एक्चुअल की PCO2 में ये मैथमेटिकल डिफरेंस आता है, देन यू विल से मिक्स्ड. इफ इट इज इक्वल इक्वल और इफ इट इज लेसर, इट मींस कॉम्पेंसेशन इज वर्किंग इन दिस केस. So we are sorted for the one that is given at the moment. Brittle asthma, we use subcutaneous epinephrine wherever possible. Otherwise, we will have to do aggressive treatment. Brittle asthma का treatment is same as that of routine asthma. Only thing is emergency rescue therapy. In rescue therapy, we give subcutaneous epinephrine. It's not that you have to give subcutaneous epinephrine in brittle asthma daily. It is only as a rescue mechanism. Otherwise, तो routine asthma के जैसे ही treat करेंगे. Y15 rule ही यही है. Okay, fine. A patient of pulmonary artery hypertension presents with irregular pulse with loud P2 on auscultation. तो लाउड P2 का मतलब तो पल्मोनरी आर्टरी हाइपरटेंशन हो गया, सो दैट शुड कॉज अ लार्ज ए वेव. बट क्योंकि एट्रियल फिब्रिलेशन हो गया तो इट वुड बी एन एब्सेंट ए वेव इन अ पेशेंट. सो द करेक्ट आंसर इन दिस क्वेश्चन इज रोफ्लोमिलास्ट. तो लास्ट में COPD में देते हैं ना यार. रोफ्लोमिलास्ट इज नॉट यूज्ड इन एस्थमा, इट इज यूज्ड इन COPD पेशेंट. आवर क्वेश्चन वाज नॉट ऑन COPD, इट वाज एस्थमा. Yeah, because the person is having atrial fibrillation, irregular pulse, so atrial twitching, and therefore there would be absent A waves in the guy. So answer is A. Okay. Next is a lady. She's having shortness of breath with angina pectoris episodes, and there is presence of aortic stenosis. Aortic stenosis will always contribute to left ventricular hypertrophy. Because of the hypertrophy component, there would be increase in workload of the left ventricle, and there would be increase in oxygen consumption of the heart. So pretty straightforward. Any chamber enlargement causes chamber hypertrophy, causes increase in oxygen demand of the heart. Yep. The next question talks about a patient with joint swelling and then pansystolic murmur. तो arthritis और carditis भी हो गया और elevated ESR भी दे दिया. तो उसने minor Jones criteria भी value नहीं दी ESR की, more than 60 in developing countries and more than 30 in developed countries. but उसने Jones criteria आपको दे दिए. तो Jones criteria क्योंकि question में mentioned है, carditis भी arthritis भी है, so the answer will become acute traumatic fever in this case. Yeps. Next is the patient with symptoms of anemia, depigmented hair, bleeding gums and diffuse hair loss. मतलब bleeding gums था क्वेश्चन में, लेकिन विटामिन C नहीं था ऑप्शन में. And then there was mention of anemia also. So the answer will change over to copper in the patient. The answer in this question is option number A. Can it be seronegative rheumatoid arthritis? No, because rheumatic की बात इस टाइम पे rheumatic की बात हो रही है, rheumatoid की बात नहीं हो रही है ना. जो rheumatoid वाले पेशेंट्स होंगे उनमें तो pansystolic murmur और mitral regurgitation नहीं आएगा ना, right? So it cannot be a rheumatoid arthritis. Pansystolic murmur implies mitral regurgitation, so that goes in favor of rheumatic and not rheumatoid. Yep, copper deficiency causes anemia, hair depigmentation, and connective tissue abnormalities due to copper playing a role with respect to activated lysyl oxidase, which is gonna be having a role in like collagen generation. So answer to this question is option number A. We can use 1.5 into बाइक और प्लस. या बेटा खुद देखो, आपके पास में एग्जाम में टाइम कम होता है, पहले मल्टीप्लाई करोगे फिर ऐड करोगे फिर प्लस माइनस करोगे. आई मीन इफ यू आर कंफर्टेबल तो मुझे कोई दिक्कत नहीं है, मेरी मैथ्स कमजोर है तो मुझसे तो होता नहीं वो वाला, तो आई डू दैट 15 एडिशन. ओके, अ पेशेंट प्रेजेंट्स विद, बट आपका पॉइंट सही है गौरव, योर पॉइंट इज परफेक्टली स्पॉट ऑन. A patient presents with hypotension with hyponatremia and blackening of knuckles blackening of knuckles in the perioral area. So, which condition would be associated? Yeah, because hypotension be a hyponatremia, so aldosterone is less, ACTH is elevated, so it becomes primary Addison disease in the patient. Secondary Addison disease may ACTH will become less, so hyperpigmentation cannot be present. In primary Addison disease, ACTH will be elevated. That is why that hyperpigmentation would come up. So standard question, salt wasting, salt craving नहीं दिया था, but hypotension, hyponatremia let you know the answer. Okay, patient is having recurrent lung infections and the heart is right-sided. So you can see the apex of the heart being on the right. That makes it easier. That is called Teneger syndrome. Version 2 of the same question will be that he'll talk about recurrent lung infections and he will also mention regarding steatoria. And sometimes as a distraction he will mention regarding bleeding in the question, because vitamin K deficiency की वजह से there can be bleeding occurring in a patient. Bleeding episodes can be described, that will become cystic fibrosis. For Dijot syndrome in a patient, he will talk about like rickets-like manifestations with calcium being less, rickets-like manifestations, delayed dentition, that could be given in the question. So I think all of these questions on recurrent lung infections have been discussed. Okay, now we come to 2023 question. He gave a line diagram showing a murmur that is present all through the duration of systole. The intensity is equal, so I would like to call it a pansystolic murmur. And that pansystolic murmur will be associated with mitral regurgitation in a patient. If the intensity was rising and falling and it was a crescendo decrescendo murmur, then I would have thought in terms of aortic stenosis in this patient. So just a quick line diagram for the same, where the intensity would be rising and falling, then I would have called it a aortic stenosis murmur. Okay, so this was, yeah, we are discussing NEET PG 2023 question. Then is this patient who came with complaints of early morning backache and stiffness that improves on exercise. That's one of the highlight of ankylosing spondylitis and persistent red eyes. There was no mention of uveitis given in the question, but yeah, persistent red eyes was given. That was a very good hint towards presentation of ankylosing spondylitis. The x-rays anyway showing a stiff spine, a bamboo spine, plus the reduced lung expansion because of costochondral lung involvement. So this was like a very easy pickup for all the students. Okay. Yeah, uveitis component, bamboo spine, so makes it easier. Coming to the next one, patient presents with hyperkalemia and elevated blood urea levels, underwent dialysis. Towards the end of the session, the patient became very drowsy. Normally तो उल्टा होता है ना कि डायलिसिस से पहले पेशेंट ड्राउजी होता है, डायलिसिस के बाद अलर्ट हो जाता है, हाइपर विजिलेंट हो जाता है. यहाँ पे क्या हुआ, उसको सीजर भी हो गया. सो दैट मीन्स दैट इसको डेवलप हुआ डायलिसिस डिसइक्विलिब्रियम. Normally when we do dialysis in a patient, the session of dialysis will be lasting for 4 hours, but जो first session होता है dialysis का वो usually हम 4 hours का नहीं करते, because rapid fluid shifts across the brain will occur. Because of the rapid fluid shift across the brain, there can be a cerebral edema developing in this patient. Rapid brain or rapid fluid shifts across the brain is the better way to describe it. Dialysis disequilibrium का मतलब है rapid osmotic changes, rapid fluid shift across the brain, which causes cerebral edema. To decrease that cerebral edema, we will have to give mannitol for management of this patient. The answer is option number D, and the question was more based on clinical science that if we are doing dialysis, we should not be doing over dialysis of a patient. Yep. Next is a patient who's come to the emergency room with severe restlessness, palpitations, and tremors. The patient is a known case of bronchial asthma. There is a diffuse enlargement of thyroid as well. So we are talking about multiple things here. One, we are talking about Graves. Now, Graves is going to contribute to sympathomimetic stimulation. And that sympathomimetic stimulation can cause a sinus tachycardia, but sometimes can cause atrial fibrillation. And at the same time, this particular patient is also having bronchial asthma. Now the question says, what will you be doing for management of this patient? Propylthiouracil would be used if there is thyroid storm. For thyroid storm, I have explained that there should be mention of fever. There should be mention of, restlessness is okay, but then there should be mention of calorie genesis that should be increased. There should be mention of fever in a patient. So I am not very comfortable with diagnosis of thyroid storm. The main problem of this patient is that the patient is having a cardiac issue. There is atrial fibrillation that can explain the restlessness and the palpitations in a patient. The tremors are a profile of that Graves' disease. The tremors are a component of the Graves' disease that causes sympathomimetic stimulation. So I would like to go for rate control in this patient, and therefore what we will do in the patient is diltiazem. The answer to this question is not beta blocker, because beta blockers are contraindicated. Beta blockers are contraindicated in a patient of asthma. This question was very smartly designed. He first talked about Graves' disease, and like the thought process was Graves' disease patient is sick. So that made everybody think that this could be thyroid storm in a patient. Your thought process is not wrong, but for thyroid storm, you need to have presence of fever. There has to be vomiting. There might be jaundice present, and then there would be like excess of sympathomimetic drive in the body. But that calorigenesis component should be taken into consideration. So that's why propylthiouracil is out. Non-selective beta blockers would not be used. They'll be used in Graves' disease, but not for management of atrial fibrillation. So we will be using esmolol for management of atrial fibrillation. But somebody said a very relevant point that esmolol is cardioselective, so can't we use it? तो cardioselective का मतलब ये नहीं होता ना कि वो सिर्फ बीटा 1 पे असर करता है, बीटा 2 पे भी तो असर करता है. Cardioselective does not mean that it will act only on beta 1, it acts on beta 2 also. So the answer in this question would be diltiazem. The answer to this question is option number A, it's the rate control. इसको मैंने सिंप्लीफाई करके बोला हुआ है कि whenever you answer beta blocker हमेशा ABCD रूल आउट कर लो. फिर से बोल रहा हूँ, A से हार्ट फेलियर हो गया, एक्यूट हार्ट फेलियर, बी से ब्राडिकार्डिया एंड बी ब्रोंकियल अस्थमा, सी से सीओपीडी और डी से डायबिटीज विलाइटस. तो कॉन्ट्राइंडिकेशंस फॉर बीटा ब्लॉकर शुड ऑलवेज बी टेकन इनटू कंसिडरेशन. Okay. Next is a patient who's hepatitis B positive, E antigen also positive, and he's having chronic hepatitis B. And because he's having elevated SGPT, and at the SGPT elevation tells me cytopathic effect of the virus, and the virus load is also high, like 2 into 10 is to power like 5 international units. So like it tells me that the DNA is like the virus is actively replicating and is causing cytopathic effect. So I would like to use treatment for this patient. What is the main treatment? We give tenofovir. Duration does not matter. There were various values that were given, 40 weeks, 52 weeks. Don't bother about it. बेटा पेगेलेटेड इंटरफेरॉन somebody commented, उसको हम यूज करते हैं ना हेपेटाइटिस सी के लिए, सॉरी हेपेटाइटिस डी के लिए. पेगेलेटेड इंटरफेरॉन इज व्हाट वी यूज इन हेपेटाइटिस डी, but for hepatitis B it is tenofovir. ना tenofovir and entecavir are two medicines that we use. Pegylated interferon beta, again बोल रहा हूँ, it is for use for management of when you are having a combination of B plus D infection. जब किसी को हेपेटाइटिस डी और बी का कॉम्बिनेशन का इन्फेक्शन होता है ना, वहाँ पे पेगालेटेड इंटरफेरॉन को यूज कर रहे होते हैं. द मेन थिंग दैट विल बी यूजिंग इन द पेशेंट इज टेनोफोवीर फॉर मैनेजमेंट. एस्टरिक्सिस पे वो इमेज बेस्ड क्वेश्चन डाल सकता है. वी आर कंडक्टिंग अ स्पेशल लाइक सेशन ऑन इमेज बेस्ड क्वेश्चंस आल्सो. सब्सिक्वेंटली उसका नोटिफिकेशन आपको आ जाएगा. बट देन एस्टरिक्सिस कहाँ कहाँ पे मिलता है? तो हिपैटिक एंसेफेलोपैथी में मिलता है. मैंने हेपाटिक एंसेफेलोपैथी नहीं लिखा है, मैं इम्प्लाई कर रहा हूँ. हेपाटिक एंसेफेलोपैथी, यूरेमिक एंसेफेलोपैथी एंड कार्बन डाइऑक्साइड नार्कोसिस, दैट इज एक्यूट एक्सर्बेशन ऑफ क्रॉनिक ब्रोंकाइटिस. इसको विंग बीटिंग ट्रेमर से मिक्स नहीं करना है. विंग बीटिंग ट्रेमर में पेशेंट का एक ही हाथ ऐसे 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 हिल रहा होगा. ट्रेमर वाला तो एस्टरिक्सिस वाले में तो ऐसे हाथ को एक्सटेंड करा के आप ऐसे एक्सटेंड करने के लिए रिस्ट पे बोलोगे तो यू विल गेट दैट फ्लैपिंग ट्रेमर. अगर वो फोटो ऐसे देते दोनों हाथ की और एक हाथ में इस तरीके से ट्रेमर आ रहा है, दैट इज अ विंग बीटिंग ट्रेमर. दैट इज व्हाट यू गेट विद विल्सन्स डिजीज इन अ पेशेंट. तो उसके इमेज बेस्ड सेशन के वो ट्रेमर्स के 4-5 वेरिएशंस हैं दैट आई विल बी डिस्कसिंग विद यू फॉर दोस इमेज बेस्ड वन. लेकिन आज का जो ऑब्जेक्टिव है दैट इज टू डिस्क्राइब ऑल द PYQs. सो एट द मोमेंट आई थिंक हम किस पे 60 स्लाइड्स पे हैं. आई थिंक माई टारगेट वॉज 1 मिनट पर MCQ. तो थोड़ा सा एक्सटेंड हो गया, मतलब 1.5 मिनट लग गया, बट चलो बाकी भी कर लेते हैं। वी हैव 30 मोर टू गो, सो लेट्स लाइक वाइंड दोज ऑफ ऑल्सो। ओके। हाँ, मतलब वो एक्सटेंशन पे आ रहा है, लिवर डैमेज वाला पेशेंट है, राइट, वर्सेस लाइक दैट विंग बीटिंग ट्रेमर, इट वुड बी प्रेजेंट predominantly in one hand. Okay. Next is a patient who came with palpitations, increased sweating in the palms, and restlessness. Eye findings are given in this case, and he says, what is the cause of this? So we know that we're dealing with Graves' disease in a patient, and whenever there's a Graves' disease, we need to figure out the answer here, and the answer in this patient would be a TRAB, that is a TSH receptor stimulating antibody. Yes, answer would be C. LATS, thyroid receptor antibody would be present here. So correct answer is option number C. Perfectly. Option A और B जो आ रहा था कमेंट में, वो तो हैशीमोटोज में हो जाएगा ना यार। जो ऊपर वाले दोनों ऑप्शंस हैं वो तो हैशीमोटोज थायराइडाइटिस में हो जाएंगे। चलो, next is a HIV positive patient with multiple lesions that bleed very easily, and then there is a capillary proliferation with neutrophilic infiltrate. थोड़ा pathological detail उसने डाल दिया, so it says what is the likely diagnosis. Pyoderma gangrenosum हम usually पढ़ते हैं inflammatory bowel disease के साथ में, mainly shins पे present होता है. Then is febrile neutrophilic dermatosis, that is called as sweet syndrome. That is again what you can, चलो आंसर्स पहले, कापोसी सार्कोमा आ रहा है, बैसिलरी एंजियोमेटोसिस आ रहा है। यार कापोसी सार्कोमा में तो सिर्फ कैपिलरी प्रोलिफरेशन होगा ना, न्यूट्रोफिलिक इन्फिल्ट्रेट साथ में नहीं होता ना। ये दोनों चीज लिखी ना, लॉबुलर कैपिलरी प्रोलिफरेशन, और फिर उसने कर दिया विद साथ में न्यूट्रोफिलिक इन्फिल्ट्रेट। दैट इज नॉट अ प्रेजेंटेशन दैट यू सी विद कापोसी सार्कोमा, इट इज ओनली अ ट्यूमर of the epithelial cells. So therefore the answer in this question is option number A, that is bacillary angiomatosis, which is a differential diagnosis of Kaposi sarcoma in the patient. The answer to this question is option number A. मेरा एक सजेशन है आप सबको, आप क्या करना, मेन वीडियोस में जो एड्स का मेरा डिस्कशन है उसको आज रात को एक बारी सुन लेना। आई एम वेरी श्योर आपने नहीं सुना हुआ है, आपने पैथो से सुना हुआ है, आपने माइक्रो से मैम का सुना हुआ है, बट आप मेडिकल पॉइंट ऑफ व्यू से थोड़ा सुन लोगे तो आपको थोड़ा सा ओरिएंटेशन ईजी हो जाएगा, क्योंकि ये टॉपिक्स तो आपने पढ़े हुए हैं, बैसिलरी एंजियोमेटोसिस का, पोसी सार्कोमा, बट अगर आप उसको सुन लेते हो मेरे हिसाब से तो थोड़ा सा आई थिंक द अप्रोच टू द क्वेश्चंस विल बिकम रिलेटिवली बेटर। ओके, आंसर टू दिस इज 1.5 पे सुनना, उसमें आगे आगे कर लेना, स्टार्टिंग में नहीं। जो इन्फेक्शंस मैंने बताया ना, वो इन्फेक्शंस को सुनना, बेसिकली दैट्स द पॉइंट आई वांट टू से। Okay, a patient is brought to the OPD by his wife complaining of difficulty in expressing emotions and not taking part in daily activities. On examination, there is presence of tremors and then rigidity in the patient is also noted. तो tremors भी लिखा है और rigidity भी लिखा है, और पार्किंसन में लेटर पार्ट में जाके डिप्रेशन भी आ जाता है, तो it becomes PDD, that is Parkinson disease with dementia. So the answer in this case will be PDD, Parkinson disease with dementia component coming in. That is why the person is having like difficulty in expressing emotions and not like taking part in the daily activities. So answer in this question is option number A. I had a very good answer, premotor cortex. If I focus only on the first point, that is like not taking part in activities and difficulty in expressing emotions, even premotor cortex is a very good component which is present, which is in the frontal lobe. Basically जो अगर ये क्वेश्चन सिर्फ फर्स्ट लाइन पे बेस्ड होता तो मैं तो फ्रंटो टेम्पोरल डिमेंशिया के बारे में सोच रहा होता। If this question was not mentioning tremors and if this question was not mentioning regarding rigidity, I would have thought in terms of option number D only. But that's why I said the diagnosis in the patient is PDD, Parkinson disease with development of dementia, which can result in development of this manifestation. नहीं, आप दोबारा से चेक करना है, ना तो ये फोटोग्राफ दे रखी है और ना ही ये हिस्टोपैथ की फाइंडिंग दे रखी है। तो कापोसी सार्कोमा होता है HIV पॉजिटिव पेशेंट में, जो एक्चुअल एग्जाम में पेपर था उसमें जो इमेज थी उसको डाला है और साथ में हिस्टोपैथ की फाइंडिंग डाली है। तो वो ठीक है कि स्टूडेंट्स जब रिकॉल देते हैं मैम को तो वो बताते हैं कि मैम कापोसी सार्कोमा पे क्वेश्चन आया था, तो मैं डिस्प्यूट नहीं कर रहा, हो सकता है कापोसी सार्कोमा में माउथ वाली फोटो होती है ना, माउथ के हार्ड पैलेट में आपको लीजन्स मिल रहे हैं, वो अलग सेपरेट क्वेश्चन है। हार्ड पैलेट में माउथ के अंदर देयर इज अ इमेज ऑफ अ पेशेंट, आप गूगल करोगे ना, अभी अभी आप गूगल खोलो कापोसी सार्कोमा डालो ओरल कैविटी, तो आपको माउथ में हार्ड पैलेट पे मल्टीपल लीजन्स मिलेंगे। वो स्टैंडर्ड इमेज जो कापोसी सार्कोमा की आई हुई है, तो मैंने तो वो लीजन की बात ही नहीं करी। दिस इज अ टोटली डिफरेंट क्वेश्चन दैट केम विच हैड दीज लीजन्स ऑन द फेस, बड़े बड़े पस्ट्यूलर लीजन्स प्रेजेंट थे। दिस वुड बी बैसिलरी एंजियोमेटोसिस। हाँ जी, हाँ जी, वो जो हार्ड पैलेट वाली फोटो है, एग्जैक्टली डॉग 5677 आपका जो नाम आ रहा है, दैट इज व्हाट इज फॉर कापोसी सार्कोमा। हाँ जी। ओके, नेक्स्ट मैं जो क्वेश्चन बोलूंगा वो थोड़ा सा डिस्प्यूटेड है, क्योंकि पैथोलॉजी वालों ने थोड़ा अलग से बताया, बट मैं आपको विद रैशनल बता रहा हूँ ये। एक HIV पॉजिटिव पेशेंट है जिसको पहले उसने टाइम वेस्ट करने के लिए बोला कफ एंड वेट लॉस, फिर उसने बोला कि स्किन लीजन्स है विच आर अम्प्लिकेटेड पैप्यूल्स विच आर प्रीडोमिनेटली ऑन द फेस। तो मेन जो कीवर्ड था वो था मलस्कम कंटेजियोसम वाले लीजन्स प्रेजेंट है कि अम्प्लिकेटेड पैप्यूल्स प्रेजेंट है। एक्सरे ऑफ द पेशेंट शोज बायलैटरल नोडुलर इन्फिल्ट्रेट्स एंड स्पूटम टीबी नेट वाज नेगेटिव। सो ऑब्वियसली इसका जो आंसर चल रहा है वो चल रहा है कि नहीं नहीं, ये जो पेशेंट है ना इसको हिस्टोप्लास्मोसिस है, क्योंकि टीबी और हिस्टोप्लास्मोसिस बहुत ज्यादा क्लोज होते हैं। तो मैं आपको बताना चाहता हूँ इसका आंसर हिस्टोप्लास्मोसिस, मलस्कम कंटेजियोसम तो है ही नहीं भाई, ये तो बिल्कुल गलत है। हैरिसन की लाइन दिखा रहा हूँ, हैरिसन की लाइन में लिखा हुआ है, मैंने इसको अपने रिकॉल में भी ऐसे ही बताया था कि क्रिप्टोकोकोसिस जो होता है वो भी लंग्स में नोडुलर इन्फिल्ट्रेट करता है। हिस्टोप्लाज्मा करता है तो क्या हो गया, क्रिप्टोकोकोसिस भी करता है। लेकिन लाइन लिखी हुई है कि जो लीजन्स होते हैं क्यूटेनियस क्रिप्टोकोकोसिस के, दे लुक लाइक दैट ऑफ मलस्कम कंटेजियोसम। ये लाइन हिस्टोप्लाज्मा में नहीं दे रखी है, हिस्टोप्लाज्मा में लंग के नोडुलर इन्फिल्ट्रेट दे रखे हैं। डिस्क्रिप्शन ऐसे आ रहा था, जो रिकॉल चल रहा था ना, जो मैम ने भी बोला है, मैं किसी को क्रिटिसाइज नहीं कर रहा, उन्होंने ऐसे बोला कि अगर CNS मैनिफेस्टेशन दे रखे थे मेनिंजाइटिस वाले क्रिप्टोकोकस के साथ, हर कोई क्या बोलता है कि CNS मैनिफेस्टेशन होंगे। भाई जरूरी थोड़ी ना कि CNS होंगे। डिस्क्रिप्शन क्या चल रहा था, डिस्क्रिप्शन ऐसा था, इफ इन द क्वेश्चन CNS मैनिफेस्टेशंस वर गिवन एंड molluscum contagiosum lesions are given, cryptococcus. If it is lung manifestation with these lesions, then it is gonna be histoplasma. No man, that is not the case. If it is gonna be lung manifestations, it can be cryptococcus, it can be histoplasma, but the main differentiating feature is that only the textbook says molluscum contagiosum के जो lesions हैं जैसे वो दिखते हैं वैसे ही परली अम्ब्लिकेटेड पैप्यूल सिर्फ क्रिप्टोकोकोसिस में डिस्क्राइब्ड है, हिस्टोप्लाज्मा में नहीं है। सो आई विल बी लाइक आई विल बी लाइक टोटली गोइंग अगेंस्ट द टाइड, लेकिन दैट इज नॉट द करेक्ट वे ऑफ डिस्क्राइबिंग इट, क्योंकि टेक्स्ट बुक रेफरेंस की जरूरत होती है, तभी मैंने यहाँ टेक्स्ट बुक की फोटो डाली है। गाइस द आंसर टू दिस क्वेश्चन इज ऑप्शन नंबर बी। मुझे पता है कि इस पे बहुत ज्यादा डिस्प्यूट होगा कि नहीं सर, हमें तो इससे बताया गया था कि ब्रेन मैनिफेस्टेशंस और साथ में स्किन लीजन्स होते हैं तो फिर हम बोलते हैं क्रिप्टोकोकस, और लंग मैनिफेस्टेशंस और स्किन मैनिफेस्टेशंस होते हैं तो बोलते हैं हिस्टोप्लाज्मा, बट दैट इज नॉट हाउ द टेक्स्ट बुक वुड डिस्क्राइब इट। सो द आंसर फॉर दिस क्वेश्चन इज ऑप्शन नंबर बी, HIV डिसेमिनेटेड क्रिप्टोकोकोसिस। ये लाइन का फोटो आप ले लेना, जो भी आपको रेफरेंस बोले, आप सिर्फ टेक्स्ट बुक का, मैं नहीं बोल रहा, टेक्स्ट बुक में लिखा हुआ है, आप मुझे दिखा दो कौन सी बुक में लिखा है कि क्यूटेनियस हिस्टोप्लाज्मा रिजेंबल्स मोलस्कम कंटेजियोसम, है ना। फिर तो नीट PG वालों के ऊपर ही बनता है कि भाई ऐसा क्वेश्चन क्यों डाल रहे हो। बट इन द टेक्स्ट बुक हिस्टोप्लाज्मा वाला चैप्टर मैंने चेक किया है, लाइन टू लाइन हिस्टोप्लाज्मा के क्लिनिकल फीचर वॉल्यूम 1 में चेक कर लेना, कहीं पे भी नहीं लिखा हुआ है वहां पे कि द लीजन्स रिजेंबल दैट ऑफ मोलस्कम कंटेजियोसम, ओनली इन क्रिप्टोकोकोसिस दिस इज गिवन। सो द आंसर टू दिस क्वेश्चन इज ऑप्शन नंबर बी। एंड तभी मैंने बोला कि थोड़ा HIV वाला मेरा डिस्कशन सुन लोगे तो आपका ओरिएंटेशन बेटर हो जाएगा। चलो अगले सवाल पे चलते हैं। A patient presented to the emergency room with seizures and there is a history of fever, headache and confusion and there is inflammation involving the temporal lobe. The moment I say temporal lobe, answer becomes very easy. It would be herpes simplex virus in this case. भाई इसका ना कई, मैं नाम नहीं लूंगा, एपोलो ने मलस्कम कंटेजियोसम भी बना दिया आंसर कि मलस्कम कंटेजियोसम विद HIV इज मच मोर एक्सटेंसिव। भाई टेक्स्ट बुक रेफरेंस के हिसाब से जाना है ना। द आंसर टू दिस इज ऑप्शन नंबर सी। डॉक्टर, मोलस्कम कंटेजियोसम जो है ना, दैट पॉक्स वायरस, उसके कंपैरिजन में इट इज क्रिप्टोकोकस दैट इज मोर कॉमन ना। HIV में जो अपॉर्चुनिस्टिक इन्फेक्शंस होते हैं, दे आर द वंस विच कॉज दैट मैनिफेस्टेशंस। वो तो इम्यूनो कॉम्पिटेंट में होता है, इम्यूनो कॉम्पिटेंट में होता है। नहीं 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 नहीं, वो इस वाली ऐप की बात नहीं कर रहे हैं, दिस इज अ डिफरेंट वन। ओके चलो, द आंसर टू दिस इज ऑप्शन नंबर सी। नेक्स्ट इज अ पेशेंट हु इज हैविंग फीचर्स ऑफ लोअर मोटर एज वेल एज अपर मोटर, क्योंकि उसने अपर मोटर भी दे दिया और उसने एम्पस्टेड एंकल जर्क भी दे दिया। सो कॉम्बिनेशन ऑफ अपर मोटर एंड लोअर मोटर के जो मैनिफेस्टेशंस होते हैं वो विटामिन B12 डेफिशिएंसी में मिलते हैं, जिसमें सेंसरी प्रोफाइल भी होता है, विच इज गिवन इन दिस क्वेश्चन बिकॉज देयर इज सेंसरी लॉस गिवन, देयर इज एंगुलर स्टोमाटाइटिस गिवन। अनदर कंडीशन which will be having this profile is amyotrophic lateral sclerosis, but that will be having pure motor manifestation. amyotrophic lateral में sensory involvement नहीं होती है, only motor manifestation would be there। और फिर होता है फ्रेडरिच एटैक्सिया, जिसमें कार्डियक इन्वॉल्वमेंट भी दी होती है और डायबिटीज की मैनिफेस्टेशन भी दी होती है। सो इफ यू गेट अ क्वेश्चन इन विच अपर मोटर एंड लोअर मोटर मैनिफेस्टेशंस आर गिवन टुगेदर, कंसीडर 3 डिफरेंशियल्स इन द पेपर: विटामिन B12 deficiency, amyotrophic lateral sclerosis, which will be pure motor. If there's a cardiac manifestation with diabetes mellitus, think in terms of Friedreich ataxia. The answer in this question is option number D, that is subacute combined demyelination of the spinal cord, SSCD. That's gonna contribute to demyelination of peripheral nerves as well as of the corticospinal pathway. That explains that peripheral neuropathy, areflexia, and then the corticospinal tract involvement will result in spasticity to develop in this patient. Okay. Then is a woman, she came with chest pain and shortness of breath, and there's a mid-diastolic murmur with prominent A wave that was present. So considering prominent A wave that is present, mid-diastolic murmur that is present in this patient, the answer would be given as tricuspid stenosis. Mitral stenosis may be hota hai, but then it would be like long-standing mitral stenosis. So the correct answer for this is tricuspid stenosis. दो क्वेश्चन हो गए. I would like to remind you, एक मैंने और क्वेश्चन आपको कराया. That would be a blunted Y descent that is seen in tricuspid stenosis. So the answer to this question is option number B, tricuspid regurgitation. बेटा इसमें तो CV wave होती है ना. In tricuspid regurgitation, there would be a CV wave that is present. That is a CV wave and a steep Y descent that is present. आपको tricuspid regurgitation ध्यान हो तो उसमें तो options थे ना कि there would be a CV wave, there would be an absent X descent, and there would be a steep Y. Yeah, the answer to this question is option number B. बेटा mitral regurgitation नहीं ना, JVP है बच्चे. JVP की बात कर रहे हैं. JVP deals with the right side of the heart. JVP deals with the right side of the heart. So that's why tricuspid stenosis will become the answer. I'll repeat that again. JVP deals with right side of the heart. उसको याद कर लो. Okay. Umbilicated pearly lesions. No, histoplasma में. If there are no skin lesions, lung involvement present, histoplasma in HIV positive patient, no problems with that. Okay. Next is the patient who's on hypertension and is on multiple antihypertensive medications, came to the OPD and the ECG finding is given below. So very smartly designed question. Hypertension का patient है, उसको BP के दवाई चल रहा है, and there would be manifestations that would hyper. तो basically मैं बोल देता हूँ स्पाइरोलेक्टॉन जो होता है वो हाइपरकलीमिया करता है, ये हाइपोकलीमिया करेगा, ये ब्राडिकार्डिया करेगा, और प्राजोसिन अल्फा सिलेक्टिव ब्लॉकर है, तो एज सच उसमें कोई ज़्यादा चेंजेस आने नहीं वाले हैं. तो ब्राडिकार्डिया तो है नहीं. आई मीन ओके, लेट मी जस्ट चेक इट आउट. हार्ट रेट भी देख ही लेते हैं ना. 1 2 3 4 5. ओके, 60 से थोड़ा सा ज़्यादा होगा क्योंकि 1 जो मैंने लिखा है वो पूरा 1 बॉक्स नहीं आ रहा ना, तो इट इज़ एक्चुअली नॉट 5, इट इज़ 4.5 टू बी प्रिसाइज. चलो बाकी देख लेते हैं. लेट्स लुक एट योर. बेटा डी तो बनेगा ही नहीं. हाउ कैन डी बी देयर? उसमें तो टॉल टेंटेड टी वेव्स होंगी ना. आप मुझे देख के बताओ यहाँ पे कहीं पे भी टॉल टेंटेड टी वेव्स हैं. टी वेव की हाइट 5 मिलीमीटर से ज्यादा हो, लिम्ब लीड्स में मोर देन 10 मिलीमीटर इन द चेस्ट लीड्स, तभी तो टॉल टेंटेड टी वेव्स बोलते हैं ना. देयर इज नो टॉल टेंटेड टी वेव्स इन दिस गाय. जो मिल रहा है आपको वो एसटी डिप्रेशन मिल रहा है. What you're getting in this patient is a very characteristic ST segment depression which is present in majority of leads. तो कौन सी, I mean ST depression is something that is seen with hypokalemia, and hypokalemia can be seen with hydrochlorothiazide in this patient. What you can pick up in this question is presence of ST segment depression. मैं zoom in करूंगा ना तो आप देखोगे ये this is ST segment depression which is present in this patient, और ये जो दिख रही है this is a prominent U wave in a patient. What you can see is a ST segment depression. And along with this, you can also notice is a prominent U wave in this patient. So the combination of ST depression, prominent U waves make it hypokalemia. And therefore, for this particular case, the answer would be given as option number C. अगर इसमें दिया होता tall tented T waves, मतलब ECG में tall tented T waves होते और साथ में ST elevation होता. If in this question there was evidence of ST elevation and tall tented T waves, I would have thought in terms of spironolactone being responsible for this guy. Okay, so this is sorted and we can move on to the next one. I mean, don't assume कि हमेशा spironolactone ही चल रहा होगा ना. Don't assume कि hypertension वाले को diuretic भी चल रहा हो सकता है. It can be a hypokalemia वाला component भी हो सकता है. P waves in lead number 2. Yeah, we can see the P waves, na? P waves in lead number 2. They're not bigger than normal. They look to be of normal morphology, but hypokalemia में subsequently the P wave height will become much more significant. But as such, if you look at lead number 2, what you can notice is the presence of P waves initially. So those are okay. I mean, these are lead number 2, the P waves which I put the vertical arrows against. For this patient, no, we'll continue the same treatment. We'll adjust the dose of diuretics. Now, I mean, hypokalemia hai, so we need to change the dose of diuretics slightly. I mean, reduce the dose of diuretics in this guy. That's the only thing that's to be done. No, beta, the answer is not D because you will have a ST elevation and tall tentative wave. There is no tall tentative wave. There's no ST elevation. It's a ST depression. अब देखो मैं zoom in कर रहा हूँ फिर से. There is a very clear cut ST segment depression. I'll use a finer font to write this here on this printout. ST segment depression is present along with prominent U waves, which is the reason why the answer in this question is not the answer that is being thought out to be. Yeah. तभी तो आजकल तभी तो थाइजाइड आजकल बहुत कम लोग लिख रहे होते हैं ना सर. थाइजाइड से यूरिक एसिड बढ़ता है, ब्लड शुगर बढ़ती है, लिपिड्स डिरेंज होते हैं, तो तभी तो थाइजाइड नहीं लिख रहे होते हैं ना मोस्टली लोग आजकल. Hydrochlorothiazide is contraindicated. No, it's not contraindicated. We give it. वो तो मेटाजोलोन is recommended. But thiazide तो देते हैं ना, मेटाजोलोन तो देते ही ना CKD में. It can be given in low GFR in a patient. मेटाजोलोन इज यूज्ड इन मैनेजमेंट ऑफ पेशेंट्स सीकेडी ना. अगर पाँव में सूजन, आंखों पे सूजन है, डायूरेटिक तो दोगे भाई. एंड यू कैनॉट गिव स्पाइनोलेक्टोन इन सीकेडी, पोटेशियम इज एलिवेटेड. पॉइंट समझ गए मेरा. सीकेडी का मरीज है, उसका पोटेशियम मान लो उसका पोटेशियम है 5.8 या 6, तो क्या आप स्पाइनोलेक्टोन लिखोगे? नहीं लिखोगे ना. तो यू विल गिव अ थाइजाइड टू द पेशेंट. व्हाट यू कैन गिव इज मेटाजोलोन इन द पेशेंट. हाँ जी. नेक्स्ट इज विजुअल hallucinations प्रेजेंट इन अ चैप. Progressive decline in daily activity, convulsions and visual hallucinations, and keeps on looking at the sky. So that would be dementia with Lewy bodies. Good job. Next is a patient who comes with complaints of polyuria. He underwent a pituitary surgery recently. ये थोड़ा डिफिकल्ट क्वेश्चन था. पिट्यूटरी सर्जरी के बाद में ना देर इज अ ट्रांजिएंट डिक्रीज इन द एक्टिविटी ऑफ द पोस्टीरियर पिट्यूटरी. लाइक द गाय, इट वाज नॉट मेंशन्ड कि एंटीरियर पिट्यूटरी या पोस्टीरियर पिट्यूटरी. द क्वेश्चन वाज ही अंडरवेंट अ पिट्यूटरी सर्जरी, मतलब ट्रांसफेनोडल सर्जरी, व्हिच वी आर अज्यूमिंग इज फॉर अ पिट्यूटरी ट्यूमर. तो व्हाट द टेक्स्ट बुक सेज इज कि जब भी किसी पेशेंट की ट्रांसफेनोडल सर्जरी होती है तो उसमें देर कैन बी अ ट्रांजिएंट. नहीं बेटा, इसमें ना लाइफ लॉन्ग नहीं होता. वो कहता है कि देर कैन बी अ ट्रांजिएंट. नो, सुनो. वो बोलता है कि ट्रांसफेनोडल सर्जरी जब करी जाती है ना, तो उसकी वजह से द सर्जन इज वेरी केयरफुल. दे डू नॉट इंजोर द पोस्टीरियर पिट्यूटरी, बट देर कैन बी अ ट्रांजिएंट डिक्रीज in ADH production in a patient, which can explain the manifestations of central diabetes insipidus. It is a transient central diabetes insipidus that develops in a patient, so we give it only for 2 weeks. The answer to this question is option number A. Again difficult question था. Again like we are discussing 2024 का, I think 2023 का पेपर now. तो this was a difficult one. Most लोग इसको लाइफ लॉन्ग ही करके आए थे. गलत नहीं है आपका थॉट प्रोसेस कि भाई सर्जन वेंट वेरी अग्रेसिव, बट देन द टेक्स्ट बुक सेज कि सर्जन इतना अग्रेसिव ऑपरेशन नहीं करेगा कि पोस्टीरियर पिट्यूटरी को खराब कर दे, क्योंकि वो तो मेडिको लीगल बन जाता है. तो ही सेज कि आफ्टर एनी ऑपरेशन ऑन द pituitary, there is a transient malfunction of the posterior pituitary because of the stress and the local bleeding that has occurred in the area, because any surgery will be associated with local bleeding. So then the answer would not be lifelong basis. It is, मैं सर आप रेफरेंस दे दो मुझे टेक्स्ट बुक का. आपका रेफरेंस मत दो, आप हैरिसन का रेफरेंस दो. मेरा ईमेल है marwahmedicine@gmail.com. मैं उस पर आपको रेफरेंस प्रोवाइड कर दूंगा. मुझे एक्चुअली इसमें डालना चाहिए था और रेफरेंस ना, फोटो डालनी चाहिए थी. आप मतलब मैंने तो ख्याल डाली. आई हैव दैट रेफरेंस विद मी. तो आप मुझे टेक्स्ट बुक का रेफरेंस दे दो, हम चेंज कर देंगे आंसर. ओके. नेक्स्ट इज अ पेशेंट हु इज अ स्मोकर एंड ही हैज कम विद ट्रांजिएंट. हैरिसन में आप देखना जहाँ पे एक्रोमेगाली का टॉपिक है ना, एक्रोमेगाली के टॉपिक में ही हैज मेंशन्ड रिगार्डिंग ट्रांसफेनोडल सर्जरी, और उसके बाद जो पैराग्राफ है उसमें ही हैज मेंशन्ड ट्रांजिएंट malfunction. Okay, so you can see a lung mass on the right hand side, and then there is like this pain. There is Horner syndrome के manifestations because there's a drooping of the eyelid. So when you look at all the manifestations in the guy with the Horner के feature भी आ रहे हैं, that is Pankos tumor. So the answer in this question would be option number A. Yep. Okay, so we come to NEET PG 2022. So the papers that we have done are 25, 24, 23, and now we are at the last paper for today, and that is NEET PG 2022. Okay, a patient presents with diabetes mellitus for the past 5 years, non-compliant with medication. Blood sugar was 500 with presence of ketone bodies, so that makes it diabetic ketoacidosis. and he says what is the next best step in management of this patient. So we need to give IV fluids to the patient and we need to give regular insulin for this patient. बेटा IV fluid तो देंगे ही देंगे, but IV fluid alone नहीं देंगे ना. IV fluid with KCl देते हैं, with regular insulin तो उसको देना ही देना होता है. No बेटा, the answer in this question is option number D. It is next best पूछ रहा है ना आपसे. क्या सलाइन से तो सिर्फ डिहाइड्रेशन करेक्ट होता ना. If the question was mainly focusing only on the dehydration component, if the question was focusing only on the shock component, I would have been very happy answering this as option number B. But because it is acidosis, for that acidosis, I need to give insulin because insulin will shut down the ketone factory. हाँ तो फिर ABG पहले करते हैं ना. We would have done a ABG and then is IV fluids with regular insulin. वो ठीक है आपका पॉइंट कि इट इज लाइक इंसुलिन IV fluids followed by 1 hour. After 1 hour we will be doing, and that is only for if there is evidence of dehydration. shock होगा तो bolus हो जाएगा. तो that points we have discussed already. बेटा 600 हो गया तो इधर तो 500 है और उसमें कीटोन्स मतलब बहुत ज़्यादा नहीं होंगे ना. हाइपरग्लाइसेमिक मैंने बताया हुआ है यार. हाइपरग्लाइसेमिक हाइपरओस्मोलर स्टेट में भी कीटोन्स होते हैं पर 1+2+ होते हैं. यहाँ पे कीटोन्स ज़्यादा होते हैं. तो अगर आप सारा का सारा केस देखोगे तो दिस गोज इन फेवर ऑफ डायबिटिक कीटोएसिडोसिस ना. ओके. If there already is hypokalemia due to systemic compensation, लॉन्ग एक्टिंग इंसुलिन तो मेंटेनेंस में देते हैं यार, इमरजेंसी में थोड़ी ना देते हैं. लॉन्ग एक्टिंग इंसुलिन तो मैनेजमेंट और डायबिटीज मेलाइटस के लिए ना, इमरजेंसी में थोड़ी ना देते हैं. इमरजेंसी में तो इट इज इधर सबक्यूटेनियस और IV इंसुलिन दैट शुड बी गिवन इन द पेशेंट. DDVAP desmopressin. Yeah, yes. Pratik, you are right for that. Okay, moving to the next one. The image I have deliberately changed. That image I've shown in my routine lectures. This time you can see that cobweb coagulum still present, still visible, cobweb coagulum. And the moment there is a cobweb coagulum with elevated proteins, low sugars, that goes in favor of tubercular meningitis in a patient. So the answer in this question would be given as option number A. Yes. Then is a HIV positive patient, and what can be used to monitor treatment efficacy, because I will be killing the HIV virus. So I need to do a PCR in a patient and that would let me know that the virus is getting killed. So viral load. So we will be doing a PCR HIV RNA. We will be doing a PCR HIV RNA to determine the efficacy of treatment. Just a quick question. In which question will you answer PCR HIV DNA? In which MCQ will you answer PCR HIV DNA? Only MCQ, वरना तो PCR ही चल रहा होता है ना. PCR से हम वायरल लोड पता लगा लेंगे, ट्रीटमेंट देंगे तो efficacy of response would be seen. Yes, vertical transmission. Yes, pediatrics, vertical transmission. If it says vertical transmission of HIV, what is the test to be done? Then it is a PCR HIV DNA in a patient. One more question. If a doctor or nurse will get an accidental needle stick injury, then what is the test that should be done in this patient for early detection? Accidental needle stick injury. What is the first test to be done in a doctor? Yeah, then it is obviously CD4 count, no? That would let you know regarding how the patient will progress. Accidental needle stick injury, and he says what is the test to be done in the patient. Sir, accidental needle stick injury with a HIV positive patient, the first thing that I would like to do is a HIV PCR. HIV PCR RNA. This will be turning positive by day 7. Like अगर मुझे prick आज लगा तो day 7 to 10 में ये positive हो जाता है. जो P24 एंटीजन होता है वो day 14 पे पॉजिटिव होता है और जो ELISA टेस्ट होता है वो day 23 पे जाके पॉजिटिव होता है. I'll repeat this again. If I get a prick from a HIV positive patient, then HIV PCR RNA will turn positive by 7 to 10th day. P24 antigen will turn positive by day 14, and that fourth generation ELISA, which will talk about both HIV1 and HIV2, will turn positive between day 22 to day 23 in a patient. So that is how we would be doing blood test in a patient. Similarly, if you ask me that a doctor got a prick from a hepatitis B positive patient, what is the test that I can do for early detection? It is a hepatitis B PCR DNA that would help me identify this. Confirm it. If he says confirmation तो पूरा PSM का क्वेश्चन है, वेस्टर्न ब्लॉट मार्क कर देना. अगर वो HIV के क्वेश्चन में बोलता है व्हाट इज द कंफर्मेटरी टेस्ट टू बी डन, तो आंसर वेस्टर्न ब्लॉट होता है, वो पहले एलाइजा करते हैं फिर वेस्टर्न ब्लॉट करते हैं जो एल्गोरिथम है। लेकिन अगर वो स्पेसिफिकली बोलता है अर्ली डिटेक्शन के लिए, अर्ली डायग्नोसिस के लिए, भाई अगर मुझे प्रिक लग गया यार तो मैं वेट थोड़ी ना करूंगा कि 3 हफ्ते बाद मुझे आप बताओगे कि आपका एलाइजा टेस्ट पॉजिटिव है। सो फॉर अर्ली डायग्नोसिस यस, फॉर हेपेटाइटिस बी ऑल्सो अगर मुझे अर्ली डिटेक्शन करना है इट विल बी अ PCR हेपेटाइटिस बी DNA। If a doctor gets a prick from hepatitis B, I will be doing a hepatitis B PCR DNA, and that would help me determine early detection of the virus, because if it is present in my blood, की surface antigen positivity तो 2 to 3 weeks के बाद में आती है, और antibody तो उसके भी बाद में आती है, antibody तो उसके बाद में भी आती है ना। We will wait for like subsequent ones to come. Okay, the next one is unilateral headache with nausea, photophobia, phonophobia. That would be migraine, that is sumatriptan. Just a word of caution, cluster headache देख लेना, retroorbital pain होगा उसमें, अगर वो बोलेगा फर्स्ट लाइन क्या करेंगे तो it would be high flow oxygen. If he says drug of choice for cluster headache, it is sumatriptan. And if he says what will be given for prophylaxis, then it is verapamil. So usually the question would be on cluster headache most of the time. Like once migraine भी पूछ लिया तो अच्छी बात है, but then cluster headache, high flow oxygen is to be taken into consideration. Okay, this is the classical bat wing edema that you can see, that classical bat wing edema is coming up. The hypertensive patient went into hypertensive crisis, is not medication, is not taking medication, so hypertensive crisis हुआ उसको, and then is gone into acute heart failure. So I will be giving Lasix in this patient, and because hypertension है तो Lasix के साथ में मुझे nitroglycerin देना होगा. Nitroglycerin is a vasodilator, so it will significantly reduce the pulmonary edema component in this patient. If this is normotensive patient, then answer will be furosemide. If it is normotensive patient and acute left ventricle failure, this was hypertensive with acute heart failure. If it is normotensive or hypotensive patient with acute heart failure, if it is normotensive patient or hypotensive patient with acute heart failure, then I will be giving to the patient not nitroglycerin. It is Lasix that would be used in the patient. I would not be comfortable using nitroglycerin because it is contraindicated if the systolic BP is less than 90/60. For ARDS, we don't use diuretics. For ARDS, we use ventilation. That is what we've discussed in the earlier part there. There is no rule of diuretics. We should be keeping the patient dry in ARDS. ओके, पेशेंट और एंटी डिप्रेसेंट प्रेजेंट्स विद हाइपोटेंशन, ये तो एफएमजी एग्जाम में भी पूछता है। एंटी डिप्रेसेंट मतलब वो टीसीए टॉक्सिसिटी वाला क्वेश्चन स्टैंडर्ड है कि एमिट्रिप्टिलिन नाम नहीं लिखा होगा, बट ही विल से एंटी डिप्रेसेंट्स and there is broad curious complexes, which means that the patient will go into VT. TCA toxicity contributes to metabolic acidosis, so we need to give soda bicarbonate for management of this patient. Next is a patient who presents with fever and night sweats. I was thinking about TB, but there is a bilateral facial nerve paralysis and there bilateral hilar lymphadenopathy. Both of these pointers go towards sarcoidosis. Hilar lymphadenopathy present in a patient and facial nerve, because bilateral parotitis hoga na, that bilateral parotitis will explain the bilateral seventh nerve paralysis developing in the patient, and the answer would be sarcoidosis. Next is a female. She presents with progressive breathlessness and cough for a couple of months, and the shortness of breath worsens in one changed position. So आप देख सकते हो यहाँ पे there is fluid present. One, we can see evidence of pleural effusion. एक लंग तो काला है जैसे होना चाहिए, प्लस साथ में फ्लूइड दिख रहा है, लंग मास भी दिखाई दे रहा है, तो लंग मास भी है, फ्लूइड भी है, तो that would be a malignant pleural effusion. There is a lung mass and there is a fluid that is present, so there would be a pleural effusion that is present in this patient. So the answer in this question would be option number C, malignant pleural effusion, because there's a lung mass. Initially I thought it could be TB, like I thought it could be a tubercular effusion in a patient, but that lung mass is very much visible and there's no cavitation. Like if suppose there was some cavitation may be present, I still could have thought in terms of TB, but it's like a lung mass and fluid, so malignant pleural effusion with the classical manifestation. Yeah, pleurodesis would be done in this case. Dot plot is the same thing ना, that fourth generation ELISA की बात कर रहे हो ना, तो फोर्थ जनरेशन एलाइजा की ही तो बात कर रहे हो ना, दैट टर्न्स पॉजिटिव ऑन डे 23 ना, तो वी वुड नॉट लाइक टू वेट फॉर दोस टेस्ट जो रैपिड टेस्ट होते हैं, डॉट प्लॉट जैसे रैपिड टेस्ट होते हैं, दे आर नॉट वेरी एक्यूरेट फॉर अर्ली डिटेक्शन, दे आर फॉर रूटीन पॉपुलेशन सर्वे। अगर एक हेल्थ केयर वर्कर को प्रिक हो रहा है तो हम अर्ली डायग्नोसिस के लिए वहाँ पे PCR करेंगे। ओके, थैंक यू गाइस। चलो अगला है पेशेंट wants to undergo tooth extraction for dental caries and patient does not require prophylaxis against infective endocarditis. pretty straightforward. अगर किसी को पहले endocarditis हुआ है, हार्ट वाल्व्स हैं आर्टिफिशियल वाले, unrepaired cyanotic heart disease, तो we will give dental prophylaxis. but AST is a low pressure shunt, तो low pressure shunt पे आपको dental prophylaxis की requirement नहीं पड़ेगी. we will not have requirement of dental prophylaxis in low pressure shunt like a atrial septal defect. ओके, हिस्ट्री ऑफ पैरासिटामोल टैबलेट इंजेक्शन फॉलोड बाय ओलिगुरिया डाल दिया था उसने. डिरेंज वैल्यूज तो ठीक है लिवर टेस्ट की, बट साथ में ओलिगुरिया भी डाला था क्योंकि हेपाटोरिनल सिंड्रोम हो सकता है. बट देन इन दिस पेशेंट VST या वी वुड बी रिक्वायरिंग बिकॉज इट्स अ हाई प्रेशर ना, LV minus RB. ओनली इन AST इट इज नॉट रिक्वायर्ड. ओके, lady came with negative urine pregnancy test with galactoria, and then there's a large pituitary tumor. The patient is not willing to undergo surgery, so what is the medicine that would be given in this patient for management? यहाँ तो मतलब ब्रोमोक्रिप्टिन और मतलब कैबरगुलिन के बीच में कंपटीशन भी नहीं है, बट इट इज सिंपल ब्रोमोक्रिप्टिन that would be given which will be used for management. Yeah, to replenish glutathione. You have a good point. Then is the irregular pulse with the pulse deficit of 20, so that is atrial fibrillation. Atrial fibrillation will always be having an absent P wave. So you can see 2022 the questions of atrial fibrillation were easier. Then they started talking about atrial fibrillation with heart failure, right? So competition is increasing gradually. Next is a patient of CLD and there is ascitic fluid analysis revealing neutrophil count of like 650. That's very high. That would be spontaneous bacterial peritonitis in a patient, and we need to give ceftriaxone for management of this patient. There is a transmigration of bacteria to the lymph nodes and then to the peritoneal fluid. So we need to give ceftriaxone for diagnosis of SBP. Any value more than 250 cells. Neutrophils have no business to be. I mean, the word to be remembered is neutrophils have no business to be in the peritoneal fluid. And if they're present, that indicates spontaneous bacterial peritonitis. Next is a patient who's having jaundice and it is alkaline phosphatase that is elevated. Serum alkaline phosphatase का अगर more than 4x elevation होता है तो it always goes in favor of obstructive jaundice in a patient. It is OJ that is to be considered in this case. Patient shows elevated bilirubin and elevated alkaline phosphatase, no? So that would be obstructive jaundice. Okay. Next is a patient who came with fever, arthralgia, ulcers and fatigue for the past 6 months, and then there's a new onset hematuria. उसने पूरा वो जो पॉप सिंगर है चलो पॉप सिंगर का नाम अभी नहीं जानते, क्वेश्चन पे चल लेते हैं. RBC cast and proteinuria is present, so that means that there is a substantial amount of damage to the kidney. और साथ में fever and then arthralgia, ulcers mouth में है, fatigue for 6 months दे रखा है, so that goes in favor of lupoid induced damage. Lupus is what we should be considering in this case. So the answer in this case would be lupus nephritis. Missed A wave JVP wala. No, I discussed that question. Absent P wave, no? That absent jugular venous pressure. Okay, got it. That would be absent A wave. Got it. JVP finding would be absent A wave and ECG finding in the patient would be, you are right, absent ECG finding and JVP finding. Great, you had a good observation there. Yeah. Why not PSGN here? PSGN में तो sore throat का history होगा ना, या तो PSGN में sore throat का history होना चाहिए या फिर उसको पायोडर्मा का हिस्ट्री हो. जैसे अभी गर्मी होता है ना, ह्यूमिडिटी की वजह से चिपचिपाहट से दाने दाने से हो जाते हैं स्क्रीन पे कई लोगों के, तो पायोडर्मा. तो सोर थ्रोट के 2 या 4 वीक्स के बाद में अगर उसमें हेमाचूरिया का प्रेजेंटेशन होता, then I would have said at post-streptococcal glomerulonephritis. But if I look at the data here, sore throat pyoderma 2 to 4 weeks, then it would be hematuria. IgA nephropathy तो only फिर हेमाचूरिया होगा ना. IgA nephropathy will present only with hematuria, और वो हेमाचूरिया तो लाइफ लॉन्ग बेसिस पे रहता है. ऐसा थोड़ी ना कि उसमें माउथ में अल्सर्स भी होंगे, उसमें प्रोटीनूरिया होगा, उसमें फटीग होगा, बाकी सारे जो फीचर्स, नो वो जरूरी नहीं है. अंशुमन आपका पॉइंट ठीक है, बट कोई गारंटी नहीं है ना कि बच्चों में होता है. PSGN तो अडल्ट में भी हो सकता है. इट इज मोर कॉमन इन चिल्ड्रन, वो तो ठीक है, बट देन PSGN तो अडल्ट में भी देखते हैं. तो इट इज लाइक द हिस्ट्री दैट इज टू बी टेकन ना, सोर थ्रोट एंड पायोडर्मा एंड ऑल दोस थिंग्स व्हिच आर टू बी गिवन. और एक्यूट इंटरस्टिशियल नेफ्राइटिस के लिए तो क्या लिखा होना चाहिए? एक्यूट इंटरस्टिशियल नेफ्राइटिस के लिए ईस्नोफिल्यूरिया होना चाहिए. देन देयर शुड बी एडमिनिस्ट्रेशन ऑफ एंटीबायोटिक्स की जैसे वैंकोमेसिन दिया हमने पेशेंट को, है ना, पीपीआईस दिए, प्रोटॉन पंप इनहिबिटर दिया, उसके बाद में उसको ईस्नोफिल्यूरिया हो रहा है, दैट इज व्हेन एक्यूट इंटरस्टिशियल नेफ्राइटिस एंड अ रीनल शटडाउन, मतलब एक्यूट किडनी इंजरी के मैनिफेस्टेशंस होने चाहिए. सो ईस्नोफिल्यूरिया, वैंकोमाइसिन, पीपीआई, एक्यूट किडनी इंजरीज, एक्यूट इंटरस्टिशियल नेफ्राइटिस. ओके, 11 ईयर ओल्ड चाइल्ड विद हिस्ट्री ऑफ स्ट्रेप्टोकोकल फेरेंजाइटिस प्रेजेंट्स विद फीवर एंड आर्थराल्जिया, उसको हमने बेंजाथीन पेनिसिलिन का इंजेक्शन लगाना है, तो वो क्या रिकमेंडेशन है? तो देर इज नो मेंशन ऑफ कार्डाइटिस, तो 21 ईयर्स तक तो देना ही देना होता है ना, 21 ईयर्स और टिल लाइक एटलीस्ट 5 ईयर्स फ्रॉम द डेट ऑफ डायग्नोसिस. तो यहाँ पे हो जाएगा डेली टिल 21 ईयर्स ऑफ एज, बिकॉज लाइक देर इज नो एविडेंस ऑफ कार्डाइटिस, बट 21 तो बनता ही बनता है. आंसर वुड बी सी. Then this question was asked in 2023 in ECG format. In 2022 was theory. कि एक patient on diuretics is showing flat T waves and prominent U waves. What is the electrolyte imbalance? It would be hypokalemia. And the same thing was reversed in the paper, and they gave a ECG, and then they mentioned drugs, and the drugs were like diuretic which you had to pick up. So the same question was discussed basically in 2023 paper also, but like the way of presentation was changed. So topic तो वही रहने वाला है. It is just that the way they will give the question will be changing. Okay, so we're coming to the last three questions for today. We've done 94 questions today in about 1.5 to 2 hours approximately. 2 hours लगा लो, 2 ही हो गए. Okay जी. What should be done to prevent post-streptococcal? No, treat the initial infection. It will not happen. Na? The ABG values are showing respiratory acidosis. Pretty simple. Extreme values थी, तो respiratory acidosis, no problems with that. Acute exacerbation of chronic bronchitis. नॉट सीन इन मेन टू बी सिंड्रोम, तो पैराथ्रोइड एडिनोमा नहीं होता है. पैराथ्रोइड एडिनोमा हट जाता है वहां से ना, इलेक्शन जीत गया था पैराथ्रोइड एडिनोमा, बट नाउ इट इज फेओक्रोमोसाइटोमा दैट वुड बी प्रेजेंट. All the remaining components would be present. And yep, finally I reached to the last question for today. That's gonna be coronary artery disease with chest pain and palpitations. You can see VT happening in the guy, ventricular tachycardia. The guy is having coronary artery disease, that means ischemic cardiomyopathy would be present. So we shall be using amiodarone for management of this patient. बेटा ओरल की जगह पे हम इमरजेंसी की बात करें, या पेशेंट अभी हॉस्पिटल आया चेस्ट पेन के साथ में, तो हम ओरल की जगह पे आईवी का बात करें तो बेटर रहेगा ना. सो इट इज इंट्रावेनस एमेड्रॉन. दोनों ऑप्शन थे, ओरल भी और आईवी भी, बट कंसिडरिंग दैट पेशेंट इज कमिंग राइट नाउ एंड यू नो देयर इज अ इंक्रीज इन ऑक्सीजन डिमांड इन द हार्ट, आई विल बी मोर कंफर्टेबल गिविंग इंट्रावेनस एमेड्रॉन फॉर मैनेजमेंट ऑफ दिस पेशेंट. So the total number of slides that are covered before you at the moment are 94, and 93 94 slides are what I've covered. So we are done for this. Megacolon hota hai na? Okay. Okay, so I think we are sorted for the last question here, that is intravenous amiodarone for this question. So thank you so much for hearing me out here, and I'll see you again for that LRR session, and we'll try to incorporate those images in the question as well. So take care guys, bye bye, thank you.